Good morning, everybody, and welcome to the Nottinghamshire Healthcare Foundation Trust board meeting. You're very welcome, whether you are with us live or whether you're watching this on catch-up of some kind. My name is Paul Devlin and I'm the Trust Chair, and I'm going to be steering us through the meeting today. We always start our board meetings hearing from either those who are using our services or those who provide services. And this morning, I'm really pleased to welcome Lynn Walker, who's our Head of Sustainability, who's going to talk a little bit about the green plan that we have as a trust. So Lynn, let me hand over to you and you're very welcome to the board.
Morning, thank you. I will just hopefully share my screen. Hopefully that's working. And I'll start. So yes, thank you for the opportunity. I'm just going to outline sort of our journey to net zero as a trust, the why, the how, and the what next. So why is our climate changing? Atmospheric gases the atmosphere contain greenhouse gases, which is namely carbon dioxide from the burning of fossil fuels, heating and transport, nitrous oxide from anaesthetic gases, so used within healthcare, methane from landfill predominantly, and CFCs, which are contained within refrigerant gases from aircon. Those gases trap the sun's energy, and that's what's causing the climate to change and the Earth's temperature to increase. So what are the health impacts of climate change? Well, they can be summarised in 6 key points, really. So extreme events, which we've suffered from recently with the storms in the past couple of weeks, but also previously flooding events which have impacted our service delivery. There's heat-related mortality, poor air quality, food insecurity, which results from changing growing seasons, weather patterns. Patterns of disease are also changing through a changing climate. And there are mental health impacts and trauma associated with flooding events, for example, and also eco-anxiety, which is a term that's become increasingly more widespread over the past few years as people are concerned about the impacts of climate change.
Lynn, just to let you know that we're not seeing your slides, but you're doing fine. It's fine you just talking through them, so don't worry about it. If you just keep on talking, we're fine. We're fine just hearing the presentation like that.
Oh, sorry, it's come up on my screen, so apologies. I'm not sure. Let me try again. I'll see if I can.
Somebody behind the scenes will sort it for you, I think, Lynn.
Oh no, it's because I didn't do it. It's because they're on my screen. Sorry.
There we go.
Oh, sorry.
We can see we can see them now. Thanks very much.
Yeah, the impacts of climate change I spoke about, and then I got to this point. So it can be classed as a vicious cycle. So climate change is becoming worse. More people become unwell. More people require healthcare services, which then in turn generates more greenhouse gases. So what's really key is that we break that cycle. Why is this important? Well, the climate emergency is classed as a health emergency, and climate change threatens the foundation of good health with immediate and direct consequences for patients, the public and the NHS. So the NHS set targets around becoming net zero back in October 2020. And within their document, they set 2 clear targets, and that's to reduce the carbon footprint to net zero by 2040. So that's the NHS carbon footprint, which is what we can immediately control. And then the footprint plus, which is the part of the footprint that we can influence rather than directly control. And the aim is to be net zero by 2045. So how will we do this? Well, every trust has been asked to produce a green plan, which is board approved. Our strategy is for the next 5 years, and it contains smart targets in 10 key areas, which I am going to briefly run through. But the key to the plan is ensuring that we prioritise interventions which improve patient care and community wellbeing, as well as tackling climate change. So our 10 key areas are as follows. We have our energy, so that's looking at reducing consumption, eliminating fossil fuels and generating our own energy on site where we can. Reducing our water usage, So that's making sure that we identify and report leaks, but also minimise use where we can and monitor and measure effectively. We have targets set around our waste, so that's increasing our compliance with legislation, reducing the amount of general waste, and then increasing recycling and reuse. Travel is an area that we're focusing on to improve the local air quality. So that's predominantly through electrification of the trust fleet, but also initiatives to reduce business mileage, support staff to travel sustainably, and looking at our own travel expenses policy. We're reviewing our estate, so very shortly there will be an estate strategy published, which is looking at how we can make our estate multi-purpose and biodiverse, so we can encourage wildlife and the space to be used by patients and staff. Key part is our supply chain, so that's looking at where we're working in partnership to improve efficiency and eliminate carbon through the products and the services we purchase. So that's looking at substituting for more sustainable options, but also looking at the locally sourced products and services, so using smaller enterprises. We're looking at our food and nutrition, so that's sourcing healthier and locally produced food to reduce carbon miles, but also offer more plant-based options on our staff and patient menus, which will hopefully improve well-being and also reduce food waste. So that's a key area we're looking at too. In terms of our care, we're looking at digital models of care and identifying opportunities for lower carbon alternatives. And we're also looking at medicines management. And finally, the last 2 points, we're looking at upskilling our workforce and involving patients and staff and carers, service users, anyone involved with the trust to become more sustainable and empowered to make a difference. And then finally, our climate is the widest one, looking at a climate change risk assessment, so making sure we're aware of where those changes can influence our service delivery, and then looking at a climate change adaptation plan to make sure that we're planning for that and minimising the risk. So what next? So it's key that we implement the plan and deliver the targets successfully and monitor and measure those. We're communicating, so we've got green pods, which are online webinars for staff to listen in to understand where they can be involved in the plan and its development and monitoring going forward. And we've got one of those each month for the next 10 months to align with the chapters of the plan. We've got a live sustainability survey at the moment where we're capturing data on staff's thoughts and worries or areas that they think we can improve. We want to involve everybody in this journey, so we've got Green Impact, which is our behaviour change campaign that staff can get involved with, and the Green Champion Network, again, which is encouraging staff to be part of the network to share and information on this agenda. Reporting, we have to report into NHS-EI and also internally for monitoring and assurance. Improving, so we want to strive to continually improve our performance. And also share learning, so we've shared our plan with the integrated care system and other colleagues so we can benefit the wider system. In summary, the climate emergency is a health emergency and action is required by everyone, but it's not too late to make a difference. Having a green plan is an NHS requirement, but reducing our emissions is the right thing to do. And these changes will deliver better outcomes for patients across the whole healthcare system, as well as protecting and improving the environment. That was a brief summary. So any questions? That's
great. Thank you so much, Lynn. If you want to stop your screen share,
okay,
that would be helpful. Let's open it up for any comments or questions. Stephen, as the non-executive director with a particular interest in this, I wondered if you wanted to come first. Oh, just to say for our audience as well that NHS-EI is NHS England Improvement.
Sorry.
Don't worry. Stephen, do you want to give a comment?
Yes, thank you, Chair. Stephen Jackson, non-executive director. I think a comment really. I mean, what a brilliant presentation, and to take such a complex problem and to distill it down into a few slides, I thought was, you know, a great piece of work. So well done, Lynn. I think it's, you know, for those that perhaps don't know, the work around the environment that's been going on in the trust for many years and across the NHS. This trust is seen very much as a leader, and I think you can see a lot of that coming through. And I think it's I think it's fantastic that that we in the NHS and here in Nottinghamshire are taking a lead position in a responsible and actually credible manner. So you know, I would really say to you know, to anyone listening, you know, this is you know, this is the right thing to be doing, and we are doing the right things.
Great, thanks, Stephen. Manjit, let me bring you in, please.
Thank you, Manjit Darby, Non-Exec Director. Yeah, great presentation. Thank you, Lynn. I think my question really is, as the NHS, we're playing catch up on sustainability, aren't we? And there is a massive amount to do in the 10 areas that you've talked about. Where are we going to make the biggest and quickest impact, and how we're prioritising our energy and efforts against those 10 priorities?
So we're just about to calculate our carbon footprint for the coming year, so waiting to the end of financial year. But the likely outcome of that is that the biggest percentage will be from our supply chain for the things that we buy. So that will be the immediate area of focus. So we've got objectives set around that. And there is a framework that's been developed by NHS England and Improvement to help with that journey over the coming years to net zero. So I think looking at it's fundamentally how we do our business. Is the key one, and then energy is obviously one, in terms of making sure we're using our estate efficiently, effectively. Reducing our consumption is key, so making sure that we can have the behaviour change, but also the infrastructure behind that supports that change. So I think they're key areas really for me.
Great, thanks.
Thank you.
Sue Elcock, please.
Hi, Sue Alcock, Medical Director and Forensic Director in the Trust. Thanks, Lynn. I think one of my comments was that you made that really accessible for people, because sustainability isn't always easily understood, and you linked it really helpfully, I thought, for what it means for, you know, patients and staff in the Trust. I mean, I've worked in the Trust for quite a long time, then had a short sort of sojourn, and it was always one of the big things in the Trust, sustainability, that it prided itself on. And I think you're also doing a lot of work across the ICS. You're really well linked in terms of the sustainability work across the ICS, which I just wanted to sort of, I suppose, from an exec point of view, highlight. And then there's a couple of real practical examples that you've sort of introduced that make a real impact for staff around, you know, the electric charging points that are in some of our premises. Staff feedback is really positive about that. And then another practical I was just going to highlight is the project that's going on at the back of Rampton Hospital in terms of planting. I'm really sad I can't remember the official title of the project, but we're planting some trees in work with ex-offenders in terms of rehabilitation, but that's all about sustainability and the environment. So I just wanted to link some practical stuff to show what Lynn's doing. So thanks, Lynn.
Great, thanks, Sue. Lynn, is there a name for the project, the tree planting project?
There probably isn't as such. It's linking in with the Queen's Canopy for the Jubilee. The wood itself that we've planted, so there are about 4,000 trees, small whips that have gone in of a variety of species, but the wood itself is being named by the patient, so that's something we're working on over the coming weeks to get that named. So I'm sure there will be an official.
Great. I look forward to finding that out. Let's take Alison and then Nigel. Alison, please.
Thank you, Paul. Alison Wilde, Interim Executive Director of Finance and Estates, and also Exec Lead on the board for the Net Zero agenda. So thanks, Lynn, brilliant presentation. And I just wanted to add a little bit to back up for the question that Manjit did. We did have our first Net Zero meeting this week, and one of the things that we are doing is looking at the baseline to monitor from for all our Net Zero projects, and there's a lot of projects beneath that. So accepting Lynn's answer that supply chain is our biggest thing that we can do at the moment, but actually we're looking at the baseline for all our projects and how we can improve and set trajectories. So actually there may be quite a bit more that we can do on top of the supply chain that will have a big impact, but until we've got that baseline, we don't know that. The other thing I would say is that the Net Zero Committee is meeting in quarterly now, and I think the work that Lynn's doing is about rolling this out to everybody. It's everybody's responsibility, patients, staff, all of us, not just the sustainability team. Although they're doing a fantastic job, it is something that we need to communicate out wider in the trust. But that's it. Thank you, Paul.
Great, thanks. And again, helpful just to bring that context of the of how embedded this work is. Nigel, please, Nigel.
Thanks, Paul. Nigel Smith, a new non-executive director, so we haven't met Lynn, but I agree, great presentation, so well done, thank you. What I'm interested in is, I understand the concept of net zero, I think you said by 2040. Is there a number or a measure of where we are in 2022?
There will be. So we're coming to the end of the financial year and we'll have all the data. So that's all the energy consumption, the utilities, transport, all of those elements, the supply chain. So we will have a footprint at, well, April, May time, we'll have a figure, but we have calculated that back for a number of years so we can see the progress that we've made. But it is just a case of getting that data pulled together. It's quite a huge spreadsheet at the moment, but we have captured all that data, but I can share data at some point later on in the year, perhaps, when we've got that baseline and then perhaps what that trajectory looks like. But
okay, yeah, thank you.
We do have that.
If we feed that data through to via the committees, that would be that I think that would be the best way. John, do you want to give a final comment and then I'll wrap this one up? John.
Yeah, thanks, John Bruin, Chief Executive. Thanks, Lynn. That was as people have said, great presentation, and you made a complex arena really understandable. It's so my question really, is there anything that you'd like us as a board or an exec team, if we had a wand, or if you had a wish list of things that you think, oh, if only we could crack on with this, or this is really important but it's not getting traction? Is there anything that's sort of in your head, don't want to put you on the spot, that you'd like us to really sort of prioritise and move forward?
Yeah, this links in nicely actually. One of the points that I did mention in the last section under our climate is training of the board. So we're registering the trust to become an approved trainer with the Institute of Environmental Management and Assessment, which is the professional body for environmental professionals. And we're becoming an approved trainer to be able to deliver that training in-house. And we're hopeful that we can deliver that to the board by the end of the year, if that's possible. That's the target we've set in the green plan. So we're hoping we can do that. So right. That would be one thing. And then we can cascade that information down then through, that everybody understands the role they play, how they can influence and assure and govern really. So that for me is a key part, and then we can lead by example.
That sounds great. I'm sure
yeah, really good suggestion, Lynn, and I know colleagues will have made a note of that for our board development programme through the year, and make sure that we can plan that in. So Lynn, as always, really good to hear from you, and a great presentation, as colleagues have said, but really helping us demonstrate that even through the last couple of years of really difficult times, I know you and your team have really kept this agenda live, and the engagement with our staff and indeed volunteers and service users has been something that's been a bit of a highlight in the midst of so much tough stuff. So really appreciate that. Thanks very much, Lynn. Really appreciate you joining us, and we'll hold on to that piece of work as we go through the rest of our board meeting today.
Thanks very much.
Thank you. So colleagues, if we can go to our formal business, and in terms of welcomes and introductions, just a few faces to welcome. First of all, we have 3 new non-executive directors with us for the first time today: Fiona Daniel, Nigel Smith and Paddy Tipping. You're all particularly welcome. Delighted to have you with us in the Trust and excited about what you will bring to the board as well. Alison Wilde introduced herself a little while ago as the Interim Director of Finance. Alison, good to have you back around the board table as well. And today we're joined by Jen Guyver, Deputy Director of People and Culture, and also Keely Sheldon, Deputy Director of Community Services. And you're both very welcome to this board meeting as well. I think that's all the fresh faces. So in terms of apologies, to note that we've had apologies from Claire Teeney and Becky Sutton, hence Jen and Keely being with us, and also from Trevor Orman, and we usually have Yolanda Martin from our comms team with us, but today I know other colleagues from comms will be providing support through the live stream for us, so thank you. If we could move to any declarations of interest to note for today's meeting, please. Stephen, I just think you've got one that you need to flag, Stephen.
Yes, indeed. Thank you, Chair. Stephen Jackson, Non-Executive Director. I've been appointed as a Non-Executive Director to the ICB. That appointment doesn't fully come into effect until legislation is before Parliament, but with effect from today, I will be helping the transition towards a fully blown ICB.
That's great. Thanks, Stephen. Just to record our congratulations to you for that appointment. I don't think there will be any specific conflicts for us today, and I know colleagues will keep an eye on that over future meetings. So we haven't received any questions from the public for this meeting. So if we could move, please, to the minutes from our meeting last month. And can I just get an indication from colleagues if you're content that those are an accurate record, please? I'll just pause to get an indication from you, if you could. Thank you. If we then move to the matters arising and the action log is there. There's one item which actually is now going to get picked up later this week. So I think we can take that as is. Thank you. I don't think there are any other matters arising that aren't covered off in our agenda today. In which case, let's move to item 8, the removal of the emergency terms of reference. Shirley, can I hand over to you to introduce this one, please?
Good morning, everyone. I'm Shirley Higginbotham, Director of Corporate Affairs. You may recall back in February 2021, as a trust, we instigated some emergency terms of reference. That was because we were trying to reduce the governance processes in light of new variants and obviously the pandemic. So this paper details what those emergency terms of reference instigated, and now we've moved back to normal boards, normal committees, etc. It's proposed that we remove the emergency terms of reference and one area of life return to normal. So if board are in agreement to approve the removal of the emergency terms of reference, please.
Thanks very much, Shirley. I think this is a pretty straightforward one for us. So I'll just pause to see if there are any questions or comments. Manjit, do you just want to bring a question in?
Yes, please. Manjit Darby, Non-Exec Director. Shirley, just wanted to ask about the other temporary architectures that we put in during COVID and whether the step down of the emergency terms of reference here are following with things like the derogations committee and everything else. So are we dismantling the totality of the architecture or just these terms of reference, please?
It's just these terms of reference. The ICT, I understand it will still be in place, and that's where the derogations will go through, and then they'll be presented to board should there be any further derogations mandated. So this is just for the board and the committees, and not for the operational aspects of the organisation.
Fine, thank you.
Could you just remind us what the ICT is, Shirley?
Incident control team meeting.
Thank you. So, colleagues, if I could ask you just to give me an indication that if you support this removal of emergency terms of reference. That's clear that you do. Thank you. It's hopefully part of the process of us getting back to whatever this new normal will be for us, and it is an important one for us in terms of our good governance. So let's move on then to item 9, the Integrated Care System, the ICS. And John, if I could ask you to give us an update on this, because I know there's been quite a bit of movement in the ICS.
Thanks, Paul. Morning again, everybody. John Brewin, Chief Executive. So there's quite a bit in this, and I just wanted to take a bit of time to run through it, because I'm aware that a lot of the language and the acronyms will be new to people, and I suppose it's the start of sort of new ways of working, really. So instead of just saying take the paper as read, I'll just spend a little bit of time to go through it. So it's really an update of where things have got to, and also a guide to where the trust is contributing across many fronts as we help to develop and further the integrated care system for the county and beyond. So that's described in the executive summary, which I think that the transformation programme that's in play offers a massive opportunity for us to tackle some of the longer term challenges, and some of the changes that are in train are really quite significant. So, for example, CGs, so care commissioning groups, will formally finish and will move to an integrated care system, and all those commissioning functions will be taken up elsewhere within organisations or within alliances as the system develops. The internal market will become much less to the fore, and hopefully this competitor in tendering of contracts and the transactional aspects of the work that we do will lessen, and we'll have a much more sort of innovative framework in which to work. But it's up to us, because we are a large part of the ICS, and it's really important that we don't see it as being something other that isn't us. So the ball is in our court. So in terms of the way I have this in my head is sort of different layers. So we talk about the integrated care system, which is, if you like, the health services within the county of Nottinghamshire. Although for the future there won't be a formal thing called an ICS. The ICS will be constructed at the top of the pyramid by two things. So there'll be an integrated care board, which Stephen alluded to earlier. So Stephen will become a non-executive director on that new board. There are chair and chief exec nominations in play, and they are recruiting to those board positions as we speak. And that'll be where the main sort of business of health, if you like, will go on at a strategic level across the county. More broadly, there's something called an Integrated Care Partnership, or ICP, which will be joint venture with local authorities, and that'll be a much broader stakeholder alliance across the health and care landscape, which will include voluntary and third sector, and will be a much, like I say, much broader alliance of people coming together to sort of set direction and make sure that we tackle the priorities that have been set nationally. And this is being mapped in 42 other largely county areas across England. Some of them are not straightforward geographies like ours, and that's the framework that we'll be working from for the future. Underneath the ICB, if you like, will be the what are now called place-based partnerships, PBPs. Nottinghamshire has 4 of these, with the recent addition of Bassetlaw, which is moving from the South Yorkshire and Bassetlaw geography to ours, and that will complement the Mid-Nots, the South Nots, and the City of Nottingham, so that will contain 4 PBPs in our ICS. You see what I mean? It's a bit of an acronym city. There's very recently, actually a couple of weeks ago, there was a new white paper describing in much more detail how these PBPs will work, and I've summarised some of the bullet points at the bottom of the page there to highlight the sort of level of oversight and performance management that is expected of these place-based partnerships. There's still, I think, much discussion to be had about exactly how these will function. For example, in the white paper, there's a description that there'll be a single accountable person for health and care in each of these places. And within the paper, though, there's little detail about how that would work, what sort of service scope of provision, what sort of finance and resourcing will flow from the ICB to enable these to work. So lots more discussion to take place about and clarification about how these place-based partnerships will work. And then underneath the place-based partnerships on the next page, there are primary care networks. So it's important to distinguish between primary care networks and general practice GPs. So primary care networks are broader than just GP surgeries and cover the whole gamut of everything that goes on in primary care. And there are 23 of these across the 4 places in the county. And they vary in size, largely depending on local norms and the geographies. So, for example, in parts of Rushcliffe in the south of the county, some of these primary care networks are very large, and in other places within the City of Nottingham, for example, they're much smaller. But there's sufficient flex within the white paper and the various guidance that's coming down for this to be fine. Hold in your heads, for example, that 90%, give or take, of mental health provision takes place in primary care before it comes to secondary or specialist providers like ourselves. So you can see that it's really important that we are aligned and involved and helping support and develop primary care networks from a specialist mental health trust perspective. And the path, if we think in terms of patient pathways and in terms of enabling people to access services closer to home, to avoid hospitalizations and to get back into recovery, primary care networks are really important parts of places to be able to develop and thrive and meet the needs of their local communities. So that's the pyramid, if you like. What starts to make things slightly more complicated within this whole transformation agenda, people will come across a term of provider collaboratives. And provider collaboratives are part and parcel of the new transformation, but they sort of, if you like, they're parallel things that can sit within an ICS, within a county, but they can also extend horizontally, and by that we mean across different geographies. So, for example, we are in a mental health provider collaborative across the East Midlands, which includes the 4 other counties of Notts, Derby, Lincs, Leicester and Northamptonshire, and that's an informal alliance at the moment. There's also something called provider collaboratives at scale, which again is another mouthful. We haven't found something else to call this, but every ICS has to have at least one provider collaborative at scale, and each large trust needs to be part of one. So further on in the paper you'll see that we're part of an evolving provider collaborative at scale with the 2 large acutes in the county, Nottingham University Hospitals and Shield Forest Hospitals Trust. And the key point to hold in your head about all of this is, you know, okay, this is fine. What differences are going to make to patients and service users? And that's a key principle of the work that we're doing. There's no point just moving the tables and chairs around, and we've really got to enter this in the spirit of making a difference. And then under bullet point 5 and over to the page, there's a summary of where our trust is involved in these various ventures. So, and again, this is where it starts to become a little bit more complex. So from an ICS perspective, our main thrust of work is around the Nottinghamshire one, but people will also be aware that we're a member of the South Yorkshire and Bassetlaw ICS. We've got services in Bassetlaw, and even though the Bassetlaw place is moving to Notts, we've also got service in South Yorkshire, and we have a medium secure unit in the forensic division that works from just outside Rotherham called Wathwood. So we're involved in, for example, some of the new ICB board work up there. We're involved as a good partner in provider collaboratives, and that takes a chunk of time to keep up with. We've also taken some lead responsible officer roles in the ICS, not an exhaustive list, but we've led some of the early parts of the COVID vaccination programme, excuse me, continue to lead on the health inequalities work, people and culture, and community transformation. In terms of the places, we lead the South Notts place-based partnership. The official role is that I am the convener, but there's a lot of work that the exec team are inputting into all the place-based partnerships, and we do attend their boards. We help support some of the development programs, and we're also on a relatively small scale putting some financial support into some posts, whether it be program or project leads, etc. And we've got mental health leads in all of the 23 primary care networks, and an increasing number from a community health perspective. And then finally, on the last page, just a bit more detail about where we are with the different provider collaboratives. So the first one is the provider collaborative at scale. Still looking for a name for that. Put them in the chat if you can think of anything appropriate. So we are the lead for this in the ICS, and like I say, we're working with the 2 large acutes, and we've just started to work with Doncaster and Bassetlaw as well, because of that switch, as I've mentioned with regard to Bassetlaw. It's important that the priorities of this align to the wider objectives of the ICS more broadly, i.e. making things better for patients. And we've just had, I think, a couple of quite successful NED workshops where we've presented what we've done so far, and provided more information in terms of what the scope of this collaborative is going to be, what the priorities are going to be, and where we are aiming to get to. And then finally, as I mentioned earlier, the mental health provider collaboratives. So these, again, to complicate matters, started before the guidance and discussions around the white paper NHS transformation came out. So we've been part of a specialist mental health provider collaborative for coming up for 18 months, where we are the lead provider for the East Midlands, providing secure forensic services. This is provider collaborative is known as Impact. It's circa a £90 million contract that we, in essence, are the commissioner for 8 other providers providing these services across the East Midlands. They include both NHS and independent sector and charity provision, and it's a very new endeavour for us in terms of taking on commissioning responsibilities. There are similar specialist mental health provider collaboratives across the same footprints, which we are a partner of, but other trusts have taken the lead for that. And we know, there is a paper later in the board, that this is something that from a national perspective we'll see more of. So it's a really important part of a national service transformation for the trust being involved with. Paul, I'm aware there's a lot of detail in there, and it may generate lots of comments, questions, but I'm happy to either take those now, but to note that we will obviously come back to this on a regular basis, and it'll be something that we'll continue to pick up in board development too. Thank you.
Thanks, John. I think it gives a really strong picture of the complex context that we operate in, but also that you've set out really clearly about how we are positively engaging with all of these different collaborative pieces of work and with the system, and seeking to play our part and indeed to influence positively. So I don't propose us getting into too much detail with this meeting. I do think, though, it does give us context for a number of the items that come through later on. But I'll just pause to see if anybody's got any specific questions or comments to pick up with John. Carolyn, let me bring you in. Carolyn.
Yeah, thanks, John. It was a really helpful kind of overview of what is a very complex new system. My question's around capacity, really. So you've talked about how involved you and the executive team are in developing this new system, but we've also got the day-to-day business of the trust, which is a significantly big trust to run. And so the question is, how are you guys all coping, and have we got enough capacity to do what's needed?
Yeah, thanks, Karen. That's a great question, and something that we do tackle at exec team and senior leadership. I think if we didn't ask ourselves that question and stayed as we were, the answer would be no. We didn't have the capacity, and we didn't necessarily have the capability, because, as I mentioned, those new functions that sit under the heading of commissioning is relatively new to the organisation. But I think for me that's the important thing, is that it's such a massive opportunity for us to help drive the innovation for patient groups that have traditionally, I think, been at the back of the queue. They're very vulnerable in society, as we all know, and despite many people's best efforts, mental health, learning disability and autism particularly, but also people with long-term physical health conditions often get overlooked. And I think as an organisation, we are one of the biggest mental health, learning disability community trusts in the country. We've got a massive amount of talent in our organisation, and the opportunity that this provides us to really influence the services that people can access, the interventions they get, and the outcomes that you know, we'd all hope for them to be able to achieve is too good to miss. And I think my view is that as a trust, we need to invest in that capacity and invest in those skills to help us achieve this. If we didn't, I think it will be a step too far. But I think this is for us to seize. Thank you.
Thank you. I mean, it's a great answer. I guess, yeah, we've got to be in it to win it, haven't we? So yeah, thank you. And
great, thanks, Carolyn and John. Fiona.
Thanks, John. Fiona Daniel, Non-Executive Director. So it's linking back a little bit actually to what you've just said, John, and also around the fact that, look, we appreciate this is complicated. It's a complex movement that we're taking to get to this point. So my question is, what thought has been given to how we make this complexity less complex for our communities that we are serving, and appreciating our key users of our services, you know, in terms of helping them to be really clear and understanding the so what. I like the way you said that, you know, what's in it for me? How is this going to really make sense for me? What thought are we given to ensure that we make the complex less complex?
Hi Fiona, nice to see you again, and welcome to the Trust Board. Great question. Well, I think that goes to the heart of our task. So I think that's the board and the exec's job to translate, if you like, you know, this highfalutin commentary and the NHS jargon into, okay, so what does that mean for me? What does it mean for our patients and service users? In a little while, I'm starting to flag what I think is a great piece of work, which is our new trust strategy. And Sarah Furley and her team, with the engagement that we've done both internally and externally, have if you like, they've held that question that you've just asked as a central pillar of the whole point of doing this is, you know, so when we talk about place-based partnerships, you know, we've got, let's say, you know, a very vulnerable family in the middle of Nottingham City that have got multiple needs, can find it much more easy to access the sorts of interventions that will help them get inputs sooner. Their experiences will be better, and their reliance on services will be less. And that sort of relates, I guess, to Carolyn's point previously, is that it's ours to grasp now, and that translation part, I think, is the key answer to what you've asked. I don't know, Sarah, you popped onto my screen if you wanted to add anything.
Sarah, do you want to add to that? And then I think we'll move to wrapping this one up after this. Sarah.
Thank you. I'm Sarah Furley. I'm Director of Partnerships. So part of my job is to externally focus into the community and work in some of this complexity. To go back to that complexity question, I think we are potentially could be at risk of talking about the form of organisations and the functions of organisations. And actually, I believe if we put the patient, the service user, the community at the heart of what we are attempting to do, whether that's the NHS or care organisations, then we can't go wrong. So for me, there is something about having a shared set of priorities, shared values, shared behaviours, and if we do that right, we'll do it well. So that would be the point that I would make. Thank you.
Yeah, I agree. Thank you, Sarah. Thank you, John.
Great. So complicated but really important for us as a board. So John, I think we just asked to receive that report and appreciate that you were very deliberately taking us through more detail than we might normally do, but it's a really good kind of check for us and a good reminder of that landscape. So if we could move on to item 10, please, which is my report. And there's just a couple of things I want to highlight, if I might. First of all, to extend my personal thanks and on behalf of the board to all of our staff and volunteers for your continued hard work. I know that in the public domain, we're talking about somehow being past the pandemic. We know that that is not quite the case for us in terms of the pressures on our services and indeed the pressures on you in delivering those services and those cumulative pressures. So big thank you. Also big thank you to staff who've been involved in the inspection visit by the Care Quality Commission, the CQC. I know John will say a little bit more about this in a moment. I also want to just reiterate an internal message that has been a really important one for us to get out to our staff, which is to acknowledge some of the dreadful things going on in the world, particularly in Ukraine, and to just remind staff who are affected by what I would call a war in Ukraine, and who have links to people, family, friends, concerns for friends and loved ones in Ukraine, that please do access support from within the trust. And I know our collective thoughts are with you. I welcomed earlier on the new non-executive directors, the NEDs, as John referred to them in part of his presentation there. I'm really pleased we've got a full board again now, and the non-executive directors are a good diverse bunch with diverse backgrounds, which will help us make sure that as a unitary board we are getting the assurances and driving what we need to do as an organisation. And just finally, two mentions in relation to a couple of equality, diversity and inclusion activities I'd been involved in. A regular meeting with the Black and Minority Ethnic Staff Network leaders with John. It's an important one that is just a regular in our diaries. And also to acknowledge that as of yesterday, February was LGBT History Month, and it was great to be able to be part of some of those events. So that's my report. I'll just pause just to see if anybody's got anything to pick up. I know we don't usually have. In which case, John, let's go on, if we can, please, to the Chief Executive report.
Thanks, Paul. Hi, me again. To echo, Paul, what you said about the dreadful events going on in Ukraine, we've put a couple of words out in my comms briefing. Anne-Maria covered that off whilst I've been on leave. To add that in terms of from a people and personal perspective, noting that, you know, without getting political about it, that, you know, people across the world, including people from Ukraine, Russia, Belarus, you know, are so against this war, and that we have avoided becoming partisan about it at all. That, you know, we're here to be, you know, considerate, kind and compassionate for all our staff and their families, wherever they're from, and let's hope that some solution is found very quickly. In terms of my report, it's already out of date, so on the main body under CQC. So I've reflected in the written part there that the CQC had arrived, and they visited the 3 forensic areas a couple of weeks ago, and then literally this morning, Anne-Maria has received a call from the lead inspector, Sarah Duncanson, to say that they're back today. They'll be visiting all our acute mental health wards, including the what are called PICUs, the psychiatric intensive care units. They're at Highbury so far this morning. They'll be here for a couple of days. We predicted this. We're ready. Many colleagues have spent a massive amount of time, not necessarily in the preparation of it, but the reason why we do this, which is to improve the quality of services that people receive. I was on a visit with Julie Atfield, Director for Mental Health Services Division, the week before last to Highbury. Went to a number of wards and went to visit the crisis teams, and as ever was completely bowled over by the professionalism of staff, and how they they continue to aspire and run such challenging services at particularly with the difficulties that we've all experienced during the last wave of the pandemic. So a huge thank you for them. And as ever, it's about showcasing some of the brilliant work that we've been doing during this time. So fingers crossed, and hopefully it'll continue to go well. That's a bit of a moving feast. So as you've already flagged, we'll see how that pans out. And in terms of where else they may go, it's difficult to judge at the moment. We know that some of our services have not been inspected since 2014, but they're using what they call a risk-based methodology at the moment. So that's essentially, rather than doing a full core inspection with many inspectors, they'll go where services are flagging on their radar. So there are some places where we're still not quite sure. Over the page, I'm on page 23. I just wanted to say a little bit about the mandatory vaccination programme, or the ceasing of that, because I know it's been a really important and anxiety-provoking issue for many people across the trust. There's a summary piece there on where we've got to. So the good news is that over 95% of our staff have received double dose of the vaccine, which is a tremendous response, and a huge thank you to everybody that's availed themselves of it. The requirements for it to be mandatory from the 1st of April are now not going to be enforced, although the national message is still that from a professional perspective, it's your professional responsibility to make sure that you get a vaccine. Now, we'll continue to provide information to support individuals that for whatever reason may be unsure, and to encourage people to do it, but it's important to state that difference. It will not be a mandatory requirement. This is, again, it's perhaps not quite so rapidly changing as it was with the sort of falling off of cases nationally and worldwide with Omicron, but the future remains uncertain. People will be aware, I'm sure, through various media outlets, as that it's always been a bit unpredictable how the pandemic's going to go, and what new variants, which will inevitably come, how toxic they're going to be. But that's the sort of position as things stand. Really important to continue to do good infection prevention and control, to be sensible, to get a vaccination wherever possible. It will continue to be available, but not mandated. On the next couple of pages, just this is a more I'll take it as read, but just I've highlighted a few things there that I wanted to talk about. I've mentioned already the trust strategy, which is coming. I just wanted to sort of signal that that's in its latter stages of being compiled. Watch out for it. I think it's a really great piece of work, and it's part of our board responsibility for it to be a live thing. And not just a document. It's a bit of a cliche. We don't want it to be on bookshelves or in digital files, but I think it aligns really strongly with some of the things that we've just been talking about. And there some services from each of the divisions that for a number of reasons been involved with of late. And I wanted to spend just a couple of a minute really or two talking about learning disability and autism. People be aware that this is a huge national priority to make sure that the quality of services provided for these people is improved. It's been, I don't mean this unkindly, a bit of a backwater for too long, and there's some real steps nationally. I've just been on the fortnightly national call with the Claire Murdoch's team, have a regular slot on this in terms of some of the things that we need to be doing as an ICS for people with learning disability and autism. Trust is well placed. We've got a really positive, strong history of providing we call intellectual disability services. So people might see IDD, it's synonymous with learning disability, LD. One of the complicating factors around all things learning disability and autism is it's not just us that provide these services. There's a whole range of provision within primary care, within social care, but there's a real focus. And one of the staggering statistics from the pandemic is that people with learning disability were 6 times more likely to die from COVID related, predominantly but not only, respiratory illness, which is quite shocking, and that's a NOTS. That figure is just over 6 times, and there's some commentary there on some of the things that we're involved with right across the spectrum, from high secure services and forensic right into the community. Wanted to flag an area that doesn't get a lot of airtime. Some of the work that we're doing in speech and language services for children and young people. The Trust hosts a really passionate and dedicated speech and language service, which I've just described some of the things that they're involved in there and some of the goals that they're hoping to achieve. Important to flag that there's a real disparity in the national resourcing for these services, and Nottingham for some time is well below the national average, and something that will be important to focus on. And then finally, in terms of from a divisional perspective, I wanted to just spend a couple of minutes, Paul, talking about the Nottingham Recovery Network that you and I visited a couple of weeks ago. If people were sitting around earlier thinking, oh, I can't get my head around what all this new ICS transformation is, what are provider collaboratives, the Nottingham Recovery Network is a really great example of this, that's been in play now for a number of years. And essentially it's a whole range of services provided by 3 providers, including ourselves, Framework, and a charity called Double Impact that's substance use charity. And this area of work is focused on alcohol and substance use services for the city of Nottingham. And it's a fantastic endeavour. It's fully multidisciplinary, and it's embedded within its community. And the providers work really strongly together. There's a real strong emphasis on co-production, working with service users, and staff engagement, and striving to continue to improve, to innovate and do better. And again, a population which has multiple disadvantages. I'm sure the team will be delighted to host further visits when we're allowed. So again, that's something we can pick up outside the board, but I just wanted to flag that because I think it's a great example of some of the work that the Trust has been involved with. And then to finish off, Paul, the latter bit of the divisional headlines from the 3 clinical divisions, which in essence are, despite the fact that the Omicron wave is receding, there's still some massive challenges, particularly around staffing, particularly around demand. Some of the demand remains astonishing in terms of what's coming through the doors. And there are many areas, wards and crisis teams are really, how to put it, despite the pandemic receding, we're still on a war footing, if you like. And I suppose for me, it reminded me that before Omicron, when the last wave was lessening, we were in a similar position, really. And I think this is the landscape that we're going to be working in now for some time, for all sorts of different reasons. The demand on our service is going to be huge, and those divisional summaries reflect that. And then the final thing, there's a lot of detail in that communications summary. I just wanted to flag something called Team Brief, which is I'm sure a term many will be familiar with. We're preparing to a relaunch of this. The first event will be in March with a redesigned, essentially a communication engagement flow down and across the organisation to replace the connecting knots and some of the other things that we put in during the pandemic, on the basis of some of the feedback that we had, and again in an endeavour to engage more people in what we're aiming to do. So like I say, there's lots more detail in there. Happy to take comment questions. Thank you.
Thanks, John. And just one before I open it up, in terms of recent awards, shortlisting and successes, I don't know if you'd clocked that there was one of our services teams had been nominated for a Royal College Hall of Fame. I've not got the detail in front of me. I don't know whether you have or one of your exec colleagues have, but it was something that had flashed across my email as something that was a highlight. So I don't know if you can reflect on that or get somebody else to.
Julie Atfield has come to the rescue. So it was one of our, I knew it was one of our acute wards at Highbury, so Rowan 1, which right. is the male acute ward at Highbury Hospital. So yeah, Royal College Hall of Fame, that's a tremendous accolade.
Thanks very much for that clarification. So let me open it up to see if there are any comments or questions on what John has both said verbally, but also is it in the rest of his paper. I know you've taken us through with some detailed supporting description, John, so there may not be particular questions. No, I'm not seeing any coming through. I do think it's again, it's just a good summary for us of the complexity that we are working in, but also a way of capturing some of the great successes that are taking place almost despite all of that context. Colleagues, I know that our next item is the integrated performance report, which is always a substantial piece for us. I'm going to suggest we take a literally 5-minute comfort break before we get into this, if that's okay. So literally just 5 minutes if we can, and then we'll restart now. Alison will steer us through the integrated performance reports. So we'll see you in 5. Okay, thanks very much, colleagues. So if we can restart, and we are on item 12, which is our integrated performance report. Alison, if we could go to you, please.
Thank you, Chair. Alison Wilde, Interim Director of Finance and Estates for the Trust. The paper is about the performance of the Trust against our regulatory and internal targets, and it's here to the board for assurance. So it highlights the exceptions against our normal trajectories. And what I will do is I will take the report as read, and then I will hand to each of my colleagues who lead on each of the sections to actually talk about any exceptions they want to highlight to the board. So I'll start that off with quality overview and hand over to Anne-Marie and Newham. Thank you.
Thank you, Alison. I'm just waiting for the red line to go around my face. Good morning, everybody. My name is Anne-Marie Newham. I'm the Executive Director of Nursing AHPs and Quality, and it's very lovely to meet you all, especially our new guests. So I've got two items I'd like to highlight to you all. At the bottom of page 33, for any of you that are looking at your board intel, there's two items. I'm going to talk about safer staffing rates, and I'm also going to talk about COVID positive cases for patients. So the first one is around wards that have a lower safer staffing rate. And when I say lower, we normally use the threshold of 85%. So the number of wards in the Trust that have experienced a significantly low staffing rate has seen a 7th consecutive month of very high level for month 10, which is our January month. And that's 17 wards reporting less than 85%. The same as previous months, this tends to affect the forensic division more, and that's represented the majority of the low filled wards, accounting for 13 out of the Trust's total 17 wards with low staffing. So the staffing challenges within forensics division remains a high major pressure, and it tends to be concentrated around Rampton. And then the second item I wanted to highlight to you all was around the COVID cases that we've had. We had a significant increase in cases over the December and January period. And for January, it went up to 121 cases. And of those 121 cases, I'm going to just explain to you what that means. Of those 121, 107 of those meant that they were infected after they were admitted to us. Now, how that works is this. We call it something called nosocomial, and you're all going to love infection control after I've finished, honestly. So nosocomial infections means that you have acquired the infection after you were admitted, and we know that because it's after 8 days. So 107 of those cases were nosocomial, which means they were infected after they were admitted, of the 121. So those are really high rates. Now, the good news is we're starting to see a dramatic drop off for February, and I'll be able to report that at the next board. So those are the two areas I wanted to highlight, Chair. Thank you very much.
Thanks, Anne-Marie. I'll just pause to see if anybody's got any questions in relation to the quality pieces. Carolyn, please.
Thanks, Chairman. Carolyn, my non-exec director. Sorry, I think I forgot to introduce myself last time round. It's a comment really, just to say at the Quality Committee we did receive a very detailed paper regarding safer staffing that was presented by Fiona Illingsworth, and the committee took a lot of time to review this and were very assured around the processes that were being utilised to try to ensure staffing was safe on our wards, notwithstanding that the extreme pressures I think that teams have been under more recently, but I say we're assured around all of the actions that were being taken.
Thanks, Carolyn. That's really helpful to just remind us of that assurance through one of our
something else?
Please.
Thank you. I just want to take this opportunity as well, particularly for our new members and any public that are listening in, is that I am going to be presenting two papers today to the board, but I wanted to kind of like almost help people to understand that there's three components. Well, in my brain, there's three components to help people understand. There's three components to staffing. The first component is to make sure you've got the right establishment for the nature of the patients that you've got and how poorly they are. So that's your first one. Your second one is, what do you do about it if you've got low rates, which is what I've just described to you today. So what do you do when you've got what you know is your establishment? You know you should have eight members of staff on that shift, but what are you doing about it? How are you filling it? You're using agency, you're using bank, you're doing redeployment. That's the second part. The third part, which we won't be talking about today, but is a really important one, is all the creative, innovative things that we do to recruit, bring in new roles, nursing associates, advanced clinical practitioners, some technician roles around medication. So there's lots of things that we do, which is the third component, to really bump up and make sure that we deliver really good quality care for our patients and carers. So there's three areas to it. Now, today, you will hear from the first two when I do the reports later. But what I've just described to you is the second bit about what is it we are doing when we've got a low fill rate.
Great, thanks for that, Anne-Marie, and we'll remember that when we come on to later items. Sue Nixon, please. Sue.
Thank you, Paul. Sue Nixon, Non-Exec Director. Hi, Anne-Maria, thanks for your introduction and the key points. Last time I asked you about the acquired infections and you told me all the good things that staff were doing about trying to ensure their own approach in terms of PPE and so on. Given the number of the increase in the patients who seem to have acquired this, have you got any comments that you can help us with in terms of how that is reducing? You've just given us a snippet to say the figures next time you think are going to be down, but could you give us some indication of actually how you're helping perhaps patients understand what they need to do to try and help protect themselves, so it's not just the staff issues but the patient perspective too?
Yeah, we have a real mixed kind of like approach by patients to COVID. Some patients don't believe in it. I think that we've made it all up. Some patients are very, very poorly, and therefore, even if we did try and describe it and explain it, they're unable to take in that information. But the third cohort of patients have been really interesting. They've been more than happy to wear masks. They've been more than happy to isolate. In fact, when I went to Wathwood and I met a few patients, they were in their rooms. They didn't like it, but they were really, really good at doing it and really adhering to the compliance of isolation, masks, hand washing. So across the whole of the trust, we've just had a very, very mixed kind of like response to it. Interestingly, when we do have outbreaks, the patients themselves have requested COVID vaccine. So that's been a really interesting one for me, especially if we have a big outbreak. With the younger patients, they've been very, very quick to say, I want my vaccine now, which is great. Not always the way that I've always wanted to make sure that they get the vaccine, but you know, we'll use anything we can. So it's just been a mixed picture across the whole organisation, and you know, good positive responses in some areas, not so in others.
Okay, thank you for that.
Thanks for that. Manjit, please. Manjit.
Thank you, Manjit Darby, Non-Exec Director. Can I just follow on from what Sue's just asked Anne-Marie, just in relation to the root cause of our sources of infection, and given the very high rate, kind of synonymous with kind of where we are with Omicron, I guess, but is this about our staff not complying with IPC policy or patients not complying with IPC policy? I didn't quite understand kind of why our rates are what they are, and do we actually really understand the root cause of the source of infection in order to be able to deal with it?
Yeah, so yes, we do, and it's very mixed. So, for example, if we get 1 or 2 cases on somewhere one of our dementia wards, we can guarantee that most of the patients will then be infected very, very quickly because of the nature of the patients, because they wander and they touch each other. It's very hard to isolate them, very hard with compliance. They don't understand how to wear masks and why they should wear masks. So once we get 1 or 2 cases on a couple of our wards, and I won't name the wards today, but we know immediately we're going to have a very, very quick transmission across the patients. With regards to staff compliance has actually been very, very good, and we do, when they have an outbreak, or even if they've kind of like been in an outbreak, they do a daily compliance audit around PPE use, hand washing and social distancing, ventilation. So there's a daily audit that's done, and those daily audits are up at the 95, 96, 97% on a daily basis. So really, really happy with those audit responses. With regards to December and January, the problem is the high community infection rate. And it was very, very hard to stop that coming in with the amount of staff that we have working in this organisation. So there was many different reasons. There wasn't just one reason, and we were able to tackle it. But we knew exactly why it happened in the areas that we got it in.
Great, thank you. And just to follow up, Paul, I know that the region were concerned about the rates of infection that we had in our organisation. Is that something that they're still concerned about?
No, we're down at 13 now. At our highest it was 57, and they were concerned, and we had them on our daily calls. We now only have to have, and this was down to their recommendation, we only have a weekly call now on a Friday called a critical incident oversight meeting. And that meeting, all the external stakeholders come to, including the CCG, the NHSI, and also the public health experts as well attend that meeting. They are more than happy with what we are doing, and they have said so to us.
Great, thank you.
Now, I have used a few acronyms there, Paul.
Yep, CCG, the Clinical Commissioning Group, and the NHSI we'd mentioned previously with NHS England Improvement. Yep, I'd spotted those, Anne-Maria.
Oh, I was there.
Thank you. Alison, let's come back to you to steer us on to the next part of this paper, please.
Thank you, Paul, and thank you, Anne-Maria. So the next section on the Integrated Performance Report is the People and Culture. So I'm going to hand over to Jen Gwyver, who will introduce herself. Thank you.
Good morning. I'm Jen Gwyver. I'm Deputy Director of People and Culture. So I just wanted to start by linking to Anne-Maria's third pillar of staffing, and just to make the link that later on in the board we have a paper on international recruitment, and absolutely agree with Anne-Maria. It's about attracting new people, of which international recruitment is one of our many strategies. Secondly, growing our own, so nursing associates, degree nurses, physicians associates, etc. The list goes on. And finally, retaining the people we have and making sure that people are happy at work, well and able to attend and give their best to our patients and clients. In terms of the people aspect of the report, the main issue for escalation, which no doubt everyone will be in agreement with, is sickness absence. So you can very much see the impact of the Omicron variant there in our January figure, which peaked at 8.8 sickness absence figure for the month of January. For February, things have improved, as you'd expect, and that's all linked to less outbreaks, less people off with COVID, and we're back down at about 7.5%, which puts us back in the region we were before Omicron, essentially December. This is an area where we've got to do lots more work during 2022 into 2023. The board will be aware that we've put significant investment into our wellbeing programme, which kicked off just as the pandemic started. So for all the right reasons, has very much been COVID focused. Pleased to say we've got 3 new people who've joined the team who are now going to lead on the 3 aspects of wellbeing. So Jonathan Wright is joining us to lead on wellbeing in general. Chris Lewis started today as our head of staff counselling, and I see that as a really crucial department to support the mental wellbeing of our colleagues going forward. And finally, Shirley Fields is heading up our new occupational health department, and I think there's a lot we can go at this year in terms of helping people stay at work, preventing them go off before they get too ill to be here. Finally, just wanted to flag our employee relations cases do remain very high. We continue to try to embed a just and restorative approach to this, but as there's oversight from the People and Culture Committee on this in a lot of detail, which I'm sure Sue will confirm, but we do have a extraordinary number of very serious cases that we have no choice but to take some formal action around, but that continues to be an area that we keep an eye on in much detail.
Thanks, Jen. There's one thing that I want to pick up. I'll just see if anybody else wants to come in first. I'll just on the trust sickness level from the statistical process chart there, whilst I appreciate that last jump was likely the Omicron related, I think it's just acknowledging that we've seen 10 months of increased sickness, and again, that whilst that makes sense on one level for me in terms of cumulative impact of what we've seen over the last couple of years, that is clearly a trend that we want to try and break. And I just wonder whether you'd got any further things to say around how we break that trend.
And we absolutely can't blame it all on COVID and get ourselves stuck in thinking that that's the case. But what you can see from that is we haven't seen the seasonal trend in absence that we would normally see. So you've got an increase when normally you have a wave each year that usually matches roughly, depending on when the flu season starts, essentially. So I think we need to unpick which of that is COVID and what is other issues. And as I say, I think they're the three key areas of my team where we'll be supporting. We've got real high hopes that the staff counselling service can be a mental wellbeing service essentially, and it's not just for staff in crisis. It's, you know, can provide coaching, can provide debriefs, critical instant support when things do go wrong and people need support. So there's loads to go at, and it's going to be a focus of the team this year.
Great, thanks. I know that you'll then pick that up for assurance and governance through the committee structure. Great, thanks very much. Alison, do you want to steer us on?
Thank you. So the next section of the performance report is our operational divisions, and we'll start with the mental health division. So I'll hand over to Julie Atfield. Thank you.
Morning, I'm Julie Atfield. I'm the Executive Director of Local Mental Health Services. So at the last month's board, I did flag that it would be this report where we did see the impact of the most recent wave. So some of the changes within our performance are largely in relation to the wave that we were experiencing and largely the staff absence through January. So I won't repeat some of the things about sickness and absence that have already been discussed, but I flag that the division's absence did peak at 12%, and indeed there were some pockets of absence in services that was much higher than that. And since the end of December, we've been running at an operational escalation level of Opal 4, which is our highest level of critical incident management. We did have a considerable number of derogations in place throughout this time, and a number of redeployed staff, of course. Some of those conditions do persist to actually the current day. We do have an absence level of 9% still in the division, which is just more than twice our usual absence. So it's a significant factor at the moment for us to manage. And we have reduced the number of derogations we've got in place now to just 9. So actually there is some positive progress, but as John and colleagues have described, it does remain a challenge. In terms of by way of performance updates, I would like to give a progress update around bed flow and the delayed discharges issues that we did discuss at the last board. So at the moment, we still have 22% of our patients who remain in beds when they would be medically fit to leave or reside in another type of placement. So that is a very significant issue for us still. And there are 27 patients delayed from our MESOP services, for example, requiring further residential or nursing care. And the issues aren't really abating in the residential sector as soon as we had hoped. Further to that, we've also got 21 people with health delayed placements who are waiting. So again, as we discussed at the last board, there's a whole raft of organisational and system escalation around these patients. They are receiving care at a level that isn't best suited to meet their needs. So since the last board meeting, we have had a multi-agency discharge event. That's a MAID event to look at how we escalate the care for those patients and their onward placement. We've worked considerably with partners on the sharing of information, and we have reviewed the process around all of that system escalation and how we manage and escalate those delays. There is an increased focus being brought to any stranded patient, and it's clear that the continuing care market needs to be stimulated by continuing care to ensure that we're able to provide the right pathways onwards. And there are some patients which are to help that process being reviewed by independent clinicians, and there is another multi-agency discharge event planned for next week, so it continues to be an area for us to focus on. It does, of course, affect our use of out of area beds, and it does affect our use of subcontracts as well, so it is a priority for the division to improve on that area. With regard to the 72-hour follow-up, this is a target that the Trust has never breached before. In fact, it's a target that we met well before it was and became a national target. And it did relate directly to the staffing loss in the crisis team. I can assure the board that all the patients who weren't seen within the 72 hours did follow up, and there were no incidents related to that. We have ensured that we've reviewed our escalation state to make sure that we have ring-fenced redeployment to secure the follow-up, and indeed our performance has been reinstated. Lastly, I'd just like to cover the Iact target around Black and Asian and minority ethnic patients. We have done some close investigation of this to seek to understand why there has been a deterioration in the recovery rate for these patients. We have singled out that this relates to patients with social anxiety, obsessive compulsive disorder and recurrent depression, and we have put in some places to change our pathway for those patients because it's been badly affected by the social isolation during COVID. We have increased the level of behavioural activation therapy that we provide to those patients and provided additional training for clinicians. And we also now have clinical leads reviewing any unrecovered patients to see if this recovery action is going to achieve what is intended. And it's also going to be subject to future clinical audits. So those are my updates for the board.
Thanks very much, Julie. And just before I bring colleagues in, just to say that Iact is our improving access to psychological therapies, and MESOP is mental health services for older people. I think I'm really acutely aware, particularly after John's earlier paper, of just how many acronyms that we are using, and it is always our intent to try and make some of this complexity as clear as we possibly can. I'll take Jen. Do you just want to come in with a linked piece in relation to absence, and then I'll bring Nigel in.
Yeah, so just to respond and refer to Julie's comment about some areas obviously have had quite severe pockets of absence, so really high percentages, well above that 8.8% that I quoted. And now we've got a bit of brain space, and we've got the team looking to analyse the sickness data in terms of what was COVID, what was isolating, and what was other types of sickness. So then we can start to put some targeted support into the areas of most need, and something that we haven't really been able to do during that wave of Omicron. So it's just to provide some assurance on that.
Thanks, that's really helpful. Nigel, please.
Thanks, Paul. Hi, Julie. Nigel Smith, Non-Executive Director. I'm new to the Trust. I just want to follow up on the discharges followed up in 72 hours. It does look as if it's dropped off the chart a bit. What is the risk of not following up in 72 hours? And I think what you said is they were caught up a little later than that. Is there any risk in that?
Unfortunately, yes, Nigel, there is a risk. This was a target put in place to ensure that people were followed up quickly after their discharge from hospital, to make sure that their protective factors were in place and that they'd got the community support in place that they needed. So not to provide that follow-up is a safety matter, and it is important that we do meet that target. It's not one that, as I say, we've always had very good performance on this, so getting that righted has been really important to us, and also ensuring that those people were followed up. It's part of the National Confidential Inquiry to make that follow up. It's well known throughout our professional structure and our service structure, so it's something that we've had to attend to rectifying very quickly.
Right, thank you.
Thanks, Julie. And that just really underscores the importance that you described of really turning that back around. Manjit, please.
Yeah, thank you. Manjit Darby, Non-Exec Director. Just a couple of things from me, Julie. One is I'm really pleased to see the work on the recovery standards on ethnic minority patients, because I think that we sometimes forget about looking at the breakdown of kind of access and improvement by ethnicity. So I'm really pleased to see that and the work that's happening on that. In relation to Iact, I think that there's something really important about the board being clear about the capacity and capability of the Iact service to be able to respond to the impact of COVID. So I just wondered if you would comment on that. Secondly, I'm also pleased to see the work happening on the MAID events, because I know later on in the community services paper, some of the knock-on effect of patient, longer reduced delayed discharges and so on. So there's something about the flow of patients in and out of our services that are impacted by our inability to get patients the right care in the right place. And I also wondered about elective recovery and whether we have access to elective recovery monies, given the impact on waits for mental health treatments that we are seeing reflected in your report, please.
So in relation to the Iact question, improving access to psychological therapies, that service largely went to remote, virtual and telephone contacts during the main waves of COVID, and they've been carefully reviewing how that has affected the delivery of the interventions in the Iact manual. And I think that now the service is obviously reinstigating more face-to-face work, which will does have a relationship with the recovery target. But there's also some closer examination going on and benchmarking about how those principles have impacted on the delivery of the treatment manual. So I think that piece of work is really important, because one of the things for us now is, of course, how to either certainly to learn from where we've been, but how to transform our services into what is quite a different set of circumstances going forward. So they are undertaking that work actually with partners. So I think that's really key. I think as well, as ever with Iact, if you start to modify your practice in terms of the manual, it will likely lead to more contacts and less income. So I think there's always that, you know, there's always that to consider. But I think we're very clear at the moment that it's meeting the needs that takes primacy, and to be very clear about the impact of the social isolation on people's recovery has been really significant, as you would expect. In terms of the NAID events, I think the impact on the social care aspect is very clear to us. Both our social care organisations have been throughout and are still in the highest level of operational escalation, and there are limitations to community support that they can provide. The focus is always on the acute sector as well, so we are elbowing our way into actually an equivalent escalation process. So I'm, you know, pleased that that work is being done, and we're giving our patients their, you know, and not, I'd like it to be an equal level of escalation and, you know, effort to the acute sector. So that's where my strategy has been over the last sort of 6 to 8 weeks. With the elective recovery money, we are investing in a whole range of inputs into community to reduce the wait. So I don't, we have put into the elective recovery part, but actually we've got the money to be truthful. This is not a money issue, it's having the right capacity. So, but we have got lots of examples of procuring that, and there's some really positive evaluations, particularly of third sector delivery.
Yeah, thank you. I mean, I think not for today, Paul, but I think that one of the things that would be really useful for the board to have a bit of time on is understanding the kind of some of the system reorganisation piece to help some of the underlying problems that we've got, for instance, and you know that the issue of staffing isn't going away, is it? So I was really interested in the work that Wigan have done, and I know that we've kind of touched on that as a board before, but the fundamental redesign of services across health and social care to address some of the, you know, underlying deficit, but also some of the staffing issues and staffing gaps that we've got for longer term. Because if it's not about money and it is about the people, then we've got to have some different creative solutions to this, haven't we? Because there's no easy answers. So thank you. That's really good, Julie. Thank you.
And I know colleagues will have made a note of that as a suggestion as well, and we'll think through the best place for us to have that kind of a conversation. Fiona, let's bring you in for the last bite on this part of the performance report, and then we'll move on. Fiona.
Thank you. Fiona Daniel, Non-Executive Director. So it kind of builds a little bit on Manjit's first part of her question. So the recovery rate that we are looking at from the Iact perspective, do we have, Julie, a further breakdown of who is probably impacted more disproportionately from a BAME perspective? I'm just very mindful that we're collectively looking at it as a collective group, but do we have a wider understanding of, you know, who is being disproportionately impacted from a Black perspective? Asians quite a, you know, quite a broad category, and if we do, great, but if we don't, could we potentially be missing or exposing ourselves to missing elements of this great service here?
Yes, so Fiona, absolutely, we do have a lot of analysis, and we have a lot of analysis about access to all our services in that way now. That's part of our divisional plan to reduce inequalities. So what we are seeing is a differential impact around Black people in the city, and that's the area where we want to work with our primary care networks to make sure that we've not just got the access right, but also the way that we are delivering the service. So what's best? Is it at the GP? Is it virtual? Is it face to face? And are there different offers in the community that we can deliver? So our our primary care network colleagues are working on that with us, and it's actually part of their re-procurement plan that we pick out those inequalities in individual areas and do respond to those. So that work is absolutely in train. We've also got some training from NHS England about making sure we do this in the best understood way, bringing in all the best practice. So that's absolutely key to the work that the Iact team are doing. That service is sort of in the middle of a re-procurement process, so that's an area where we've been targeting quite a lot of energy. So.
Thank you. Thanks, Julie.
John, you want to come in just before we move on, John?
Yeah, yeah, just briefly, I just wanted to highlight, because I think there's a couple of really important points that have come out of that conversation. I put one in the chat, but I realised not everybody will be able to see that. Is that that delayed discharge and people being in beds that don't need to be in, that Julie's described, is a really good example, that Manjit has also commented on, as how collectively we could work together within some of the things that we were talking about earlier. Okay, so what is the ICS for? And rather than different organisations from different sectors try and battle it out, this transformation agenda gives us a real opportunity to, from a patient perspective, start to really reset some of the ways that we work together. And the other point is around, if I can say Iact now, because you've explained what that is. Despite the fact that we're all thinking, well, you know, that's a very general number for recovery rates, one of the few services across the whole of mental health that's actually got an outcomes target in terms of recovery at 50%. And yes, it's great to start to begin to unpack that and look at the differentials within the different patient groups. But again, from an improvement perspective and making our experience and interventions and outcomes better for patients, this is again now much more in our grasp, that we can start to describe, rather than just counting bums on seats or the number of people that come to a service. We can start to describe, whether it's from a formal commissioning perspective, but more from a provider collaborative perspective, some of the really important outcome things that patients and service users really value. And that could be something that's really important for the future landscape that we're working in. I just wanted to sort of pull those threads out, because I think it's important for us, and it helps sort of, I think, demystify some of the jargon that we were talking about earlier. Thanks.
Thanks, John. That's really helpful for us. So, Alison, do you want to steer us on, please? Thanks,
Thank you,
Julie.
Paul. So I'm going to hand over, the next section is on our Community Health Services division, so I'll hand over to Keely Sheldon to pick up any variances she wants to highlight. Thank you.
Hiya, thanks, Alison. Keely Sheldon, Deputy Director for Community Health Services. So just to bring some highlights and escalations from our IPR reporting this morning, I think first to note on a really positive that we're really proud of our achievement against the 2-hour urgent response standards that we've implemented ahead of national mandate in April, and we're achieving successfully around our community access target. I just want to assure the board this morning that we feel that this can be sustained. We have secured increased funding into our model, so we can successfully operate 8 while 8, 7 days a week. That will bring online extra capacity to sustain that achievement of accessibility for urgent care across Nottinghamshire. In second to that, I think the first escalation is around Lingsbar Hospital, and I believe that Julie and John's alluded to the difficulties or the complexities around the system that we're operating in around flow and discharges and available capacity in our interlinking provision, namely for us at Lingsbar, those packages of care for individuals to ensure that we can discharge home. We have taken critical learning around our increasing length of stay. So as Julie alluded to, we've also had a multi-agency discharge event focusing on community beds and our flow and discharges. And we've taken critical learning around how we can apply some discharge to assess principles in discharging patients in our home provision, really applying predicted dates of discharges for our individuals within our provision. We're also engaging within a series of community services webinars around timely discharges and really looking around what we can learn from our acute trust around criteria-led discharges. So hopefully really kind of getting some operational grip on our flow to achieve those PDDs moving forward. But as John alluded to, really engaged in our discharge board discussions across the system around thinking creatively differently around what offers do we have for our patients and citizens to ensure home first principles are implemented. And then thirdly to mention is the surgical podiatry. I can inform you that obviously I think some of this was a planned deterioration because of Omicron, and we've had several derogations in situ that's ensured a deployment of this resource into that urgent care world. I think that it will sustain as this picture for February, but from that point, all derogations have now discontinued. So we're looking likely to be planning a recovery plan for surgical podiatry ahead of the 7th of March. And I'm really pleased to be informing you today that we have 0% of sickness within surgical podiatry. So our resilience of our workforce to ensure that we can do this recovery plan to meet the referral to treatment times for surgical podiatry, we feel well assured that we can move on this within the next 4 months. This is the picture that we saw throughout Omicron. I would like to say this isn't the picture that we saw in wave 1. It was a worse picture, and we successfully recovered surgical podiatry within a period of 4 months, and we feel that we can do that again, learning from wave 1. And that's everything that I feel I need to discuss this morning. Thank you.
Great, thanks, Keely, and I'm really pleased you added that detail around the surgery there, because last board we heard a very positive experience from Marie of the podiatry services, and I think just having that sense of your understanding of what the service have been able to do earlier in the pandemic is a really helpful piece of assurance for us. I was paused to see if there are any questions or comments for Keely. I don't think there are, Keely, so Alison, could you steer us on, please?
Thank you, Paul. So over to our final clinical division, our forensic services. So I'll hand over to Sue Alcock. Thank you.
Thanks, Alison. Sue Alcock, Forensic Director and Medical Director in the Trust. In terms of the forensic escalations and highlights, it's very similar to what I shared at last board, which obviously covered December, and going into January was a very similar picture for us in terms of our staff that were available for work. And I use it in that terminology because it's not just about sickness, it's about a whole variety of factors. And as colleagues have said already, we've got an underlying high level of sickness rate, which is primary causes stress and anxiety, on top of then having the Omicron wave. So then we had more staff that were isolating. We looked particularly at high secure, which is talked about in here in terms of 15%. In terms of environmental factors, I think Manjit asked the question earlier of Anne-Maria, do we know why? Anne-Maria said it's very varied. You know, we have one way in and out of the hospital for 2,000 staff, which we've been managing, but there's a lot of environmental factors around there as well. So I think the other thing that adds into our pressures was around the use. We don't have a sort of external bank, it's an internal bank, and obviously if those people are unavailable to assist in terms of bank shifts. And also, if I'm very honest, colleagues are really tired at the end of 2 years, and then to be hit by this. I think there's a lot of people who are very, very resilient and robust who have been saying just that this is, you know, so we've done a lot of work around what sort of psychological support, and I think the work that Jen's highlighted in terms of the new departments for counselling, etc., are going to be really useful to help us support staff in this. In terms of other highlights in the report, occupancy always gets escalated in the IPR for us, and that's for a variety of factors which I won't go into detail. We've talked about it before, but some of the work that we've highlighted in terms of the division, in terms of this trust strategy and what that means in our division, is work around what our care pathways need to look like to meet the sort of current and future patient demand. And that's in line a little bit with what John said about the focus nationally on services for people with LD&A, so learning disability and autism conditions, and what that looks like. I'll stop at that point because those were the two main issues.
Thanks, Sue. Carolyn, please.
Thanks, Sue. Sue, my question's about the occupancy, because as an acute nurse, we kind of work in an opposite way. Lower occupancy is generally a good thing rather than a bad thing. So my question is, it is what it is, but are there patients waiting to get into the system that are stuck, that we know about in, say, the criminal justice system and things, trying to get into those beds? Or is it just a case of we just haven't got as many patients at the moment?
It varies. So for High Secure, we had a high waiting list for the National Learning Disability Service, which has been worked through jointly with commissioners as well. So there's a weekly escalation call where they prioritise who comes in jointly. So that's a particular issue, but that's pretty much resolved now, so that's improving. In terms of the medium secure, that is much more part of the impact work in terms of, are the care pathways that are currently, well, have been in existence for the last sort of 20 years, do they meet the future patients, particularly around the LD&A service line and pathway provision. So we've had quite a few beds that are closed across, well, not just the region, but nationally around LD&A hospitals and settings. So we don't traditionally provide a service line for that. So I won't get into impact business, but impact looking at that piece across the region. So we're part of that. Low secure, I think that's, to be fair, I've said this before, it's a blip in the sense we haven't got people waiting, but normally we don't run sort of under occupancy in low secure. That's normally so we're just sort of monitoring that to see, because that's starting to go up a little bit.
Okay, so it's a kind of variable picture. It's a bit like I suppose if we just count who's in the beds, it's understanding the context around that and whether there are patients trying to get into the service or out of the service. That's the helpful context. Thank you.
I think we can think about how we update that, because occupancy figures are a bit blunt. So when we're refining our sort of reporting, I think that's what we need to look at.
Thank you.
I think that's a really helpful suggestion, Sue. I know I was just acknowledging that for the women's service, we've got probably sufficient dots there for some trends that aren't necessarily what we would want them to be. But again, the rationale behind that and the understanding of the context behind it is something that I think would be useful if you could do a bit of thinking on how to bring that through, and again using our committee structures, but also whether there is indeed any extra narrative that you'd want to highlight into the board report. So I think that's a helpful suggestion. So Alison, shall we move on? And I think you're steering yourself to yourself, aren't you, for this one?
I am. Yeah, thank you, Paul. So yes, Alison Wilde, Interim Executive Director of Finance and Estates, and here to update and assure you on the finance position for us as a trust. So in terms of our overall view of finances this year, it's a positive position. We're on target to hit our revenue, capital and our financial improvement target, and that is going to be closely monitored over this next year, but nothing to actually highlight to you for this year. What I would say in terms of the finances this year, that we have been funded via COVID blocks, so that's given us the income assurance that we've needed this year. And also the reason that we've not been able to recruit staffing, as we've described it throughout the whole board. We've not been able to cover shifts on ward with bank and agency due to the pandemic, so that has given us some underspends on pay that are non-recurrent and won't be repeated. So we've also managed to actually contain our capital spend, particularly with the issues that we've had with Sherwood Oaks and increased spend that was unplanned for. So all good in terms of the finances. What I would say is that next year is going to be a challenge for us as a trust. We have delivered our financial improvement target of 8.8 million this year, but 5 million of that is non-recurrent, so we need to address that and carry that forward into next year. Also next year we will have the loss of some of the blocks across the NHS system, so that will be a challenge for us to get occupancy and activity back up to pre-pandemic levels, and trying to assure ourselves that we'll get the maximum income we possibly can from our commissioners. So this year I'm assuring you that we will get where we need to be. Next year it adds us some additional challenges. So I'll pause there and wait for any questions. Thank you.
Thanks, Alison. Stephen, let's bring you in with one or two questions. Stephen.
Thank you, Chair. Could I have a couple of questions, please, if that's okay? Morning, Alison.
Morning.
Good report, and I suppose we should start out by acknowledging that it's quite an achievement in the circumstances that have passed, both to the finance team and to the senior leadership team more generally, to come up with such a positive outcome for the year, and as we're now in the last month, I think there's a fair amount of confidence that we'll get there. My questions are firstly around the payroll award, and perhaps you can confirm whether I'm reading this correctly or not, but it seems as if the amount of money that we've been given is more or less covering the position that we have, but that position is only saved by the fact that we don't have a full establishment. As we return, hopefully, to a fuller establishment next year, is that award then not really going to cover us, and is it adding to the pressures that you talked about for next year? And if so, to what extent?
Thank you, Stephen. So yes, good question. You're right, it's only our inability to recruit and the levels of staffing we've been able to secure that has meant that pay's okay this year. In terms of the direct question on the pay award that we were given compared to what we needed was £1.2 million short for a full financial year, so we've managed to contain that, but that is an ongoing recurrent pressure. We are looking at the position for next year, and it is likely that there will be a shortfall on the pay award that we are given nationally again, and we're working that through on an individual basis at the moment. So you're right, it is a pressure. We've built that into our financial plans going forward, and we will try and meet it non-recurrently next year as well, in the same way, well, hopefully not in the same way. Let's hope we get the staffing levels that we need, but it is built into it, to assure you it's built into our financial plans for next year.
Thank you. My second question is around capital, and I was pleased to hear what you'd said, but as the year runs down, we're quite a bit behind the run rate in terms of the capital spend. We've now, when the report was written, we'd only got 2 months. At the time of speaking, we've only got 1 month to spend really what is an awful lot of money. Can you give us some assurance that that we are going to to get towards the levels that you projected?
Yes, so thank you, Stephen. So yes, just for assurance, there have been a lot of awards of capital funds really late on in the financial year, and that's been the same nationally. So we've had a lot of unified tech funds into our IT department, which we had bid for, and we were lined up to spend that. So there are, I know that there are a few £1 million going through as we speak in terms of that. I would also say the other area that we are late on spend is Sherwood Oaks. So we had plans in place that we would normally have spent that earlier. We have put those into place and bought everything that we possibly can, and that's all lined up for the year end. Obviously our supply chain could be an issue, but we've done everything to manage that risk we possibly could, and given that we're on the 1st of March and a month to go, at this point I think we'll be okay, because we've put orders in to actually ensure that we meet our requirements of the capital funds.
Okay, thank you, Alison. Thank you, Chair.
Great. Nigel, please.
Thank you, Paul. Morning, Alison.
Morning.
Obviously, I'll get a chance to go through some of this in more detail when we meet, but I am a bit worried about the financial improvement programme containing 5 million of non-recurrent savings and only 3.7 million of recurrent savings. I just want to check the implications of that. What I'm taking from it is the 3.7 million will flow through to next year, so that's good news.
Yeah.
The 5 million won't. Does it mean that all of the things being equal, our costs are going to be 5 million higher next year than this?
So thank you, really good question. You're right, the 3.8 million flows through, but the 5 doesn't. So because it's non-recurrent, we've got to repeat that next year. So it gives us a greater challenge, and the reason we're in this position now is that as part of the government response to COVID, our financial improvement plans were actually paused so that the clinical divisions and the trust can focus on the response to COVID. What that does mean is that we're paused, but actually we've now been tasked nationally with you need to catch up on your financial improvement target. So we have built into the next 3-year plan to try and get to a break-even target as a system. What that looks like to us at the moment, if we carry forward £5 million from this year and next year's target, that it's in the region of 3.5% FIP that we need to achieve. So that's quite a huge task for us, given that needs to be achieved for a full year with effect from the 1st of April. So it's going to be a challenge, and that equates to over £20 million FIP for next year. So that is absolutely what needs to be our focus as a board and a trust about how we deliver against our financial improvement plans going forward, well, target going forward, because we need to actually focus on putting some plans together. That has, like I said, it's been paused during the COVID pandemic, so that the clinical divisions could focus on that. Does that answer everything you've asked?
Nigel, what you've also picked up on something that non-executive colleagues asked about over our last couple of boards, and I know that you'll continue to bring scrutiny through the Finance and Planning Committee, where there'd already been a lot of scrutiny with the programmes. Carolyn, do you want to come in, and then I think we'll be able to wrap up, I hope, for this one. Carolyn?
Yeah, thank you, Alison. It's a bit of a follow-up question to Nigel's, please. So given the challenge of the financial improvement plan for the coming year and the fact that we're end of February, can you just give us an idea of where we are with those plans now for next year?
So we're in an honest opinion, we were in a really early stage. We're at a position we've gone out to recruit twice now for a financial improvement programme manager that I'm hoping will be in place very soon. We've got in our finance committee coming up at the end of March, there will be a paper on how we propose to move forward on our financial improvement plans, and we are looking at doing it differently. It's not about salami slicing in the old way, it's about looking at a whole scale project. So for example, we need to look at an oversight on estate and where we're going on that and what can we do. We're looking at the trust estate overall and looking at a workforce strategy across the trust and how we can and sometimes invest in our workforce to actually get savings later in the financial year. So we're in the very early stages in that, and I think Sarah might want to come in terms of our planning process of that as well. I see she's just can't come in. Thank you.
Let's bring you in, Sarah.
Thank you, Sarah Furley, Director of Partnerships. So I'm answering this question as I have exec responsibility for annual planning. So this year we've been through a process where we have rigorously prioritised the types of investment that we want to make next year. And we've done that in light of the financial position that Alison has just described. And what we've also got is an investment committee that reports into the Finance and Planning Committee. What that investment group is going to do is it's going to balance our investment priorities against our FIP priorities. And should that be out of kilter, for want of a better word, we'll try and balance it through that investment group. And should there be any ad hoc priorities that come in during the year, which is normal, again, we'll do that check and adjust to make sure that our investment is also matching our FIP. So that's the process that hopefully will put some control measures into this year and manage that as the year progresses. Thank you, Paul.
Thanks, Sarah. Carolyn, does that help give you?
It helps. I think I still have a high level of concern, as I'm sure you guys do as well, in that the later in the year that we finalise these plans, the more pressure there is, because obviously we're not making those savings from the beginning of the financial year and we're just pushing the bump in the carpet along. So I hear what you're saying about recruiting people and the plan, Sarah, and obviously we're aware of that. It is something that I think we as a board are going to have to be really focused on going forwards. But thank you.
I think that's helpful. And Alison, if you can sort of take away in part that that clearly there's board interest in this as well as for the Finance and Planning Committee, and work with colleagues about the best ways of keeping us informed how the pace is going with this.
Absolutely, yes, thank you, Paul. And I think the next Finance and Performance Committee will start that process and will feed into the board in April. So thank you.
Great. Okay, thank you very much. As ever, a lot for us to get through in that the integrated performance report. So if we move on to item 13, the local mental health services waiting time, position and plan. Julie, over to you, please.
Thank you. Julie Atfield, Executive Director of Local Mental Health Services. I'll try not to use acronyms, but it might extend the length of time that I'm talking. So I'd like to start by providing some contextual information that should really accompany this paper for board members to understand fully the operating context and where we have been. And where we are now. And then I'll talk about the key areas, the 4 key area priorities we have around weights, and I'll articulate our forecasts and issues around each of those groups. The 4 areas presented are the areas where we have long waits and where, if you like, they're not small specialist services that are long-term plan targets, but they are obviously our key priorities in terms of reducing any long waits. So I haven't covered crisis services, for example, or Iact, or non-local services. So these are absolutely the key areas. In terms of the numbers that you see, you should consider them in the following context. So the local services division sees 10,000 patients a month, well over 10,000 patients a month. 32,000 new patients a year, and we currently have 62,000 community patients. So it's just to provide assurance that we are a large mental health trust. Although some of our numbers in this report are large, there is assurance that we do have flow. So just like to talk briefly about some of the changes that we've seen in the use of local services, particularly over the last 2 years and obviously during and through COVID. There has been a previous paper to the Quality and Risk Committee which talks a bit about how our services, how the use of our services has changed. And just by way of comparison, if we compare the last 6 months to the same period in 2019, just to say that we have seen a 6% in overall increase in referrals, but within that there are some significant differences. So, for example, referrals to crisis services have seen a 70% increase, a 50% increase, with 70% increase in crisis contacts. Our local mental health services contacts have also increased by 34%. And our CAMS crisis, so that's children and adolescent mental health services, have seen an increase in referrals of 72% and a 70% increase in contacts. So overall, that gives us a high demand for crisis services, which has an impact on some of the way it's described, obviously, and seeing more acute patients, and obviously seeing patients needing much more input from services during the current time. So in terms of the 4 key waiting areas, we've described each of the main ones in our paper. We have a clear trajectory to improve our local mental health team weights and achieve the national target, which will be a new national target in 23-24 of 4 weeks. We have detailed the investment and the activity about how we plan to achieve that target to the strategy committee, and our progress against recruitment and activity has been shared previously with the board through that route. Our current waiting time has significantly improved actually since 2020 for those both waiting for assessments and treatment, and those waiting over 18 weeks has reduced by 3/4. So despite actually the need for more contacts, we have made good progress to reduce those local mental health team weights. In terms of benchmarking for community mental health team weights, we are actually on a par. The average national wait is 7.9 weeks for treatment, so we are in that ballpark as such. So that's a positive and improving picture. In terms of psychological therapies, this has been a long-standing issue for the Trust, which we've started to make some changes in relation to. So this is people waiting for specialist psychology and psychotherapy. We have actually, in the last couple of months of last year, we have increased the workforce by 3.8 whole-time equivalents. And since December, our waits for assessment have started to reduce, and they have actually reduced by 20% since September. So we are going to see some progress there. And in the next 6 months, we should see the wait definitely fall to under 26 weeks, which is the current target. So just to say, that is a long wait. It's still a long wait for treatment, but those people are usually in contact with other services and having their needs met elsewhere, but this is for the more complex psychological treatment that then they are requiring. Child and adolescent mental health services, CAMS, is the area where we are putting now the most effort, obviously, to reduce those waits. We have just procured some external capacity to provide 100 extra appointments per month for the next quarter, and that should reduce our waits roughly for 80 people and develop some good progress to reduce those weights. There's a lot of work going on to change the service as well, so to introduce some new cognitive behavioural therapy and goal-based programmes. They've had some very positive feedback from young people and their families when we've made those changes. So having piloted those, they are going to be more broadly implemented. We've also introduced a new single point of access to make sure that nobody with any other needs is being delayed because they're waiting. And also we are working closely with other children's services in the system because we don't provide all of the services. This is the sort of higher end for people in most significant need, but it's to make sure that the other child and adolescent mental health services in the system are delivering the most effective service before people need services at this level. So the national average wait for those services is 8 weeks to the first appointment. So we have got to improve our performance in this area. So there are active plans for that. So the area in the report that has the largest numbers is patients waiting for specialist services for attention deficit hyperactivity disorder and autism spectrum disorder. So this was a new service started in the Trust in 2020. Previously, those patients were not well served, finding services in primary care and in secondary mental health where their needs were certainly not met. And actually, autism services particularly is a national issue for mental health. We took the decision 2 years ago to ensure that patients started to have access to a specialist service, and we are well ahead of other providers actually in addressing this area of unmet need. The volume of activity does far exceed that was envisaged, and we are currently now increasing capacity in the service. The board can be assured that the patients are subject to a waiting well policy and that all of their assessments are triaged on referral, and that anybody who has dual diagnosis needs has their mental health services needs met while they are waiting. So we are working with another provider, and we have procured an extra 350 assessment slots to be delivered in the next quarter, as well as we are recruiting new staff ourselves. It is proving to be a popular service for professionals to join actually, and it's well needed and becoming very well regarded. So that there's a lot of work going on there, but I am assured on our trajectory that we can reduce anybody over waiting 6 months to at least by a third. So I think that's really positive. So whilst challenging this is and has been, local mental health teams particularly, their weights have been subject to a lot of work over the last 2 years to make sure all the weights are recorded properly and managed properly, and we are very transparent in our use of that information and how those referrals are managed. Each service has a full waiting well policy which describes the information that's provided to services, their contacts available to them, and access to any sort of crisis services that they might need. They have programmed follow-up calls and to ensure that their needs can be escalated in the meantime. And each waiting well policy has a clear procedure for escalation. So I appreciate there's a lot in the report. I've tried to provide some context and some updates in terms of benchmarking and the trajectories. There are very clear metrics for all of these services, and we do have good flow despite some of the challenges that were described. The services are well described in the integrated performance report, although I will be clear and add the autistic spectrum disorder service and the ADHD service and the psychology weights to be in the forward integrated performance report, so that the board has that to reference against the trajectory to see the improvement. Thank you.
That's great. Thank you, Julie. And it's been a really important one to bring that level of detail to the board. I think it's the impact of weights is something that we've talked about previously as a board, and the complexity of the challenge in having impact on those. But it feels like you've really described there a number of significant pieces of work that are starting to have the impact that we want, and I know that we'll can keep on getting that scrutiny. John, let me bring you in.
Yeah, thanks Julie. It's a really comprehensive paper, and thank you for compiling it. Just wanted to reiterate a couple of things Julie said right at the start. This is obviously from a mental health and learning disability perspective, we do plan to describe these weights more fully over forthcoming boards. And I just wanted to draw a parallel. So we all sort of read and see in the media about something called elective care weights, and the waiting lists in the NHS are over 4, 5, 6 million. And have escalated dramatically during the pandemic. Mental health and learning disability numbers aren't included in that. We don't use the same language currency as elective care, but in essence, this is the same thing. So these are people that aren't necessarily acutely unwell, needing urgent and emergency care, but need some form of specialist and skilled input. And largely go, or up until recently, have largely gone unnoticed in systems or nationally. And there was a sort of national piece of work, again coordinated by the Claire Murdoch's National Clinical Director team, estimating that there are about 1.6 million people at least waiting nationally in England for some form of mental health learning disability intervention, as Julie's described the detail about that. And it sort of links in with this parity of esteem, so that it's that these very vulnerable people are on the national agenda now in terms of priority. And the first thing that we need to do from a trust perspective is to know our numbers, know what our situation is, and then we can really start to target where to make the biggest impact, as Julie started to describe. So just sort of flagging that there's going to be more of this over the coming months for the board to get stuck into. Thanks.
Good. Thanks, John. A couple of questions coming to you, Julie. Start with Manjit, please. Manjit.
Yeah, thanks. Probably just following on from what John said, really. Throughout that presentation of that report, Julie, you were talking about us commissioning additional services and additional support in order to address the waiting. I'm interested in where the commissioner sits in this and what the commissioning response to the increase in demand has been, and where that conversation is happening. Because if we are responding by kind of increasing our commissioning activity internally, what are the commissioners doing?
Thank you, Manjit, for that controversial question. Well, actually, they are the decisions about additional procurement are made in partnership. So that's, that is evident, and it's evident in our processes. So they're all agreed through contracting and through contract executive. The increasing demand, I think this is a question that we are pitching back quite a lot on, not just to commissioners but to NHSE, about the long-term plan investment was developed at a point in time. Does it still hold water in terms of future demand and so forth? So that conversation is very much live, and not just for us as an organisation. The commissioning activity is now falling to us in increasing volume at the moment. We're managing that. I think that's a point for discussion at the commissioning committee, because our current structure doesn't, really allow for that activity, and the skill set of a service manager is not necessarily the same as a contract manager. So, that does need addressing. We are very careful in the processes that we use in an evaluation and contract monitoring and so forth. But for this to be growing, it's an area that organisationally we do need to address, and we're not I'll be candid and say we're not seeing the shift of resources to move with that activity, and that is nothing that my colleagues are not aware of.
Yeah, I mean, it's one that we will need to pick up in the commissioning committee, Paul, because I think that if this is going to be a model for the future, then I think that our infrastructure needs to be different in order to be able to deal with it. Thank you. Thanks,
Manjit, and colleagues will have noted that for the committee agenda. Nigel, please.
Thanks, Paul. Hi, Julie. I want to just ask about children and adolescents mental health services, and in particular how you go about, given the fact that it will need extra resources and different ways of working, how you go about bringing the waiting list down, because the average hides quite a distribution. So looking at the chart on bottom of page 65, that 96 children have been waiting more than 6 months, if I understand that correctly. Do you, when you're trying to reduce the average, do you go to the longest waits first?
We do both, actually, Nigel. I never like to move away from the longest waits, actually. We have some waits through choice. We have some waits around geographical capacity, for example. So we move capacity round so that we can equalise out any geographical impact. There's things like people don't like travelling. A lot of CAMS activity, children's activity, sorry, moves around school time as well. So we have to flex our capacity around that. But our eyes are always drawn to the longest, actually, and actually reviewing and those to see what is it that's stopping them from getting within services. Sometimes it's not us as such that's making that a longer wait, but we have to be clear if it is, for example, it's geographically to do with capacity, then we have to make some adjustments. So within services, everybody's got team thresholds for assessments, for contacts, for outcomes, for discharge, for programmes. So it's managed in a kind of productive way around a sort of lean methodology. We try to have systematic programmes for you know, eight sessions of therapy for particular types of need, but again there is some allowance for individual therapeutic need and tolerance. For example, looked after children often require much more, so that's children cared for by the local authority. So there is a lot of complexity in managing it, but we do try to have as much standardisation of the capacity that we can bring in to make sure that we're maximising all of the contact slots, we're reducing do not attends and so forth. So there's quite a lot of sort of just normal sort of waiting time, waiting list management and productivity management into the process. Bringing in the extra capacity from partners. There's quite a lot of been quite a lot of positive feedback about the new programme, so we're always willing to try some different ways of activity. We've done things like replace individual therapies with groups. That has some benefits, particularly around using some of the online technology to do that. And online resources are a big thing for the younger people's groups. So that's what some of the Helios is that's referred to in the paper. So that's online therapy. So there isn't one answer to managing this issue, but we're throwing everything at the children and young people's waits at the moment. It was the same way we used to feel about local mental health teams. Now we've got hold of that and it's going in the right direction. This is getting the same treatment now.
Okay, thank you.
Great, thanks for that, Julie. I think it really good to get some of that detail around the mitigations that are in the plan now, and I get a real sense of that kind of grit and determination to actually resolve this, and keeping a real focus on those individuals who make up these lists. Colleagues, I'm going to suggest we take another comfort break till 1:15, please, and then we will resume with an aim of hopefully reaching the end of our public board by about 1 o'clock. So if we can restart at 1:15, please. Okay, if we could restart, please. And we go to item 14, the establishment review report. Anne-Maria, over to you. You did flag this in an earlier piece of the meeting. Thanks.
I did, yes. Thank you very much, Paul. My name is Anne-Maria Newham. I'm the Executive Director of Nursing HPs and Quality, and I'm presenting to you what I'm going to call Pillar 1. So this is about us assuring you that we have in place a really good process for doing establishment reviews across the trust, and that's across all of our wards. We actually have 71 wards, and I think that's a really important point to note, because it just shows the scale and size of the organisation and the work that needs to be done. So there is a requirement by NHS England and Improvement that twice a year you do an establishment review. We do once a year a desktop review, and once a year we do a full panel review to make sure that we've got the right amount of staff for the amount of patients per ward. So I'm going to draw your attention to page 69. So, like I said, this is a requirement that we do based on the National Quality Board's 2016 expectations. So all the establishments, apart from CAMS, which is Child and Mental Health Services wards, were felt to be safe, sustainable and effective after we did this review. So a business case has been developed to increase the staffing within the 3 child and mental health service wards, and risks are being mitigated using bank and agency. Now, a key theme that we've drawn out from all of the inpatient wards was the higher than expected level of clinical activity and risk within the female wards. And our operational directors have been very clear and given us a heads up that things have changed with regards to activity and acuity of our patients in many of our areas. And it was just to also say that the mental health services for older people, and in there you'll see it as MESOP, the community teams are also due to begin an establishment review from February of this year. So that's started. So the establishment setting has to be done annually with a mid-year review. And on page 69, you've got some bullet points there, and those are the areas that you have to consider when you go through the establishment review to make sure that you have got the right staff and the right people in place. So the child and mental health service wards were identified as a risk because of the clinical activities I've described. And that's compared to what their current budgeted establishment is. So you get a budget which gives you the establishment, and then what happens once the review's been done, if it says actually you need more staff than you've currently got a budget for. So all of the 3 wards have been benchmarked low against evidence-based staffing tools that we've currently got and that we use, and also triangulated against our professional judgment. So we often use professional judgment. You might get ward managers or senior staff that will say, do you know what, I know it says we've got to increase our establishment, but actually how we are working, how we are running, the kind of patients we've got, I feel that we're safe. Sometimes they'll say, yeah, I absolutely agree with that review. I think we need more staff. So the board is asked to receive this assurance on the trust's ability to meet the required expectations around an establishment review, which we have actually done in respect of the, I think it was 63 wards that we've done so far. And that's all I need to say today.
Thanks very much, Anne-Maria. That's clearly presented for us. Not seeing any questions or comments coming in. I think there will be more coming back to us as you described there. So thank you very much. Let's, in that case, move on to item 15. John, the Employment Tribunal judgment.
Yeah, thanks, Paul. So this paper provides an update and assurance on actions the Trust is taking in response to a recent employment tribunal pertaining to an ex-employee of the Trust. And in summary, over 3 occasions between September 2020 and March 2021, the Trust attended an employment tribunal to defend a claim of constructive unfair dismissal and victimisation. And the judgment on the in June 21 was a unanimous decision of the tribunal, was that the claim succeeded. And the process now is that the claimant is entitled to compensation, the detail of which will be decided at what's called a remedy hearing, which will occur later in the year. The Trust, we public acknowledged that it respects the judgment. We didn't appeal, and we're working through the lessons learned, taking actions in response and sharing these with colleagues. That internal action plan is appended to this brief paper, and this, in summary, in the bullet points at the bottom of page 72, summarise what we've done in terms of some of the formal requirements. Current and previous employees have referred themselves to GMC, and we've doing a lot of work at looking at the maintaining high professional standards, training for the board, to the NEDs specifically as they oversee these, and also working with the L&C and medical staff committees to make sure that we cover those off. So that's the summary of where we've got to. Because this is essentially still in play, in as much that there's the remedy hearing still to come, and still some formal processes under in action. We are a little bit constrained as to some of the detail that we can talk about, but hopefully that gives a summary of to the board, Paul, of where we are with this. Thank you.
Thanks, John. And I just tease out one of those bullet points as well, that Manjit, as the senior independent non-exec director, has commissioned a full lessons learned debrief by an independent party, which I think is just another piece of that ongoing scrutiny. But you're absolutely right. Just to be exercising some care just at the moment around what we can say further. So hopefully, colleagues, that gives some assurance on the processes that are ongoing. And obviously, as a board, we are engaged with the maintaining high professional standards training, as you identified, John. So let's move on to item 16, please, the staff survey initial results. A bit of a teaser paper, this one, Jen, I think, but if we can go to you, please.
Hi, Jen Gwyver, Deputy Director of People and Culture. Yeah, so at the moment, this is just an update really for board's assurance that we're expecting to be able to publicly discuss and act on our staff survey results from the end of March. But just to assure that there's work going on in the background before that public embargo is lifted in terms of a board development session and work with some of our EDI networks and divisional specific work. The main headline that we can share at this moment in time is that our response rate did improve this year, which is really great, a good indicator of people being engaged if they actually wish to participate in the survey. So that improved from 55.6% in 2020 to 56.9% in 2021, and it's above our comparator average. And that's all we have to say at this point, but there will be more detailed analysis, including what we're going to do about what our staff have told us in upcoming months.
Great, thanks, Jen. And obviously that will come back through to the public board in due course. So again, I'm not sure there's anything further that we need to say on that one. Let's move on, John, if we can, to the operational update on the response to Omicron and winter pressures, please.
Yeah, thanks, Paul. In more traditional style, I'll take this paper as read. There's quite a lot of detail here. I thought it was important to assure the board on the vast amount of resource and effort put into managing the Omicron wave. It's described there in some detail. Just to reiterate the headings that we supported the ramp up of the vaccination programme across the county, as Anne-Maria and others have described, managed the huge increase in COVID-19 outbreaks. A priority, make sure that patients and service users were treated in line with the latest clinical research, and supported staff in being able to maximise their availability despite the challenges that we discussed earlier. And from a more compliance and assurance perspective, coordinated the audit trail and around the clinical derogations that that were made at the during the Omicron wave, and to just to reiterate how we've kept board appraised of those as they've come, and hopefully we can sign them all off and finish them at some point in the future. So to just a sort of summary paper on all that, Paul. Thank you.
Thanks, John. I'll just pause to see if there's any comments. Just to clock a typo on page 80, I think that under the forensic services, it was from 22nd of December 2021, not 2011, that we were enacting Silver Command.
Oh no, I think it's 2011.
Is it?
No. Well, we'll get those. We'll get that amended.
That's yeah. That was just one of those numbers just to spot. Okay, thanks for that, John. And just really to say that whilst that's quite a short paper, it does capture a massive amount of work there. And much of that on top of a lot of people's day jobs. So it is a really important one for us to acknowledge as a board. So if we could move then to item 18, the seasonal flu campaign final report. Anne-Maria, back to you, please.
Thank you, Paul. Just trying to get my paper up, sorry. Welcome everybody. This is a requirement by ourselves just to sign off the seasonal flu programme that we put into place. We ran that from September of last year through till the end of February this year. The national target for our campaign was 85% of all frontline staff to be given the vaccine. I cannot tell you how difficult that was, and what a challenge that has been, because I feel that COVID really was the only play in town, and the only thing that people wanted to be able to go for. So we did really struggle, even though we put on lots and lots of clinics. We did roving clinics. A couple of our vaccinators were coming in during the night, weekends. So we have struggled. So we were unable to reach the target, although it was offered to all staff. So from a total of 8,866 staff, that's the amount of frontline staff it was classed as, 4,765 were actually vaccinated, which left just over 4,000 outstanding. So that was 54% of the eligible workforce that received the vaccine this time. Now, those figures were taken from something called the IM form that we used to return, and it was an electronic national system. Now, that reporting system ceased from the 3rd of February because it was also doing the COVID numbers as well. So we no longer have access to that system at the moment, and we're just working out with the UK Health Security Agency about how we access that system to get future figures. I'm just going to go now to page 84. So just to say about the dedicated set of peer vaccinators delivered 71 scheduled flu clinics, but they also did lots and lots of roving ability to really sort of like just drop in. But staff were so busy. We had a lot of outbreaks. There was times when staff couldn't leave the wards. So we really did struggle to be able to free up staff to be able to go out and get their jab, even though we were going onto the wards as well. We did see, interestingly enough, a good number coming forward for the very first time to be vaccinated against flu. Now, I don't know if that's just a repercussion of COVID and getting used to having that jab, but so yeah, we had people coming forward for the very first time. We did a really good campaign. Comms really helped us a lot. So the communication team helped us a lot from September last year. And we promoted the benefits of getting the flu. We had some people talking about their own case studies. We had a prize draw, which seemed to generate a lot of interest. And like I said, the staff stories were really, really well received. We've put some recommendations in there for the next year's campaign, and I will keep going. This is not going to defeat me, I've decided. And that's all I've got to say today for the report. Thank you, Paul.
Thanks, Anne-Maria. And I know there were some additional helpful documents that were in our reading library for us to provide further evidence behind this report. So just pause to see if there are any questions. We've been asked to sign off the healthcare worker checklist in the supporting documents,
yeah.
And then also to sign off and close the flu campaign as you've described there. And I think doing that, noting your determination for next year as well, Anne-Maria. So colleagues, could you just give me an indication if you're content to approve both of those as described there by Anne-Maria? Thanks, that's great. Okay, let's move on then to item 19, the East Midlands Alliance Common Board Paper. John, you referenced this in your piece earlier on about system working as part of the context. Over to you.
Yeah, thanks. Me again. So there's quite a bit in this paper, but I want the board to focus on some of the specifics in the appendix, which is the collaborative agreement. So I'm going to really focus on page 95, which is the executive summary. The main body of the paper describes in some detail the various work programmes that are being undertaken under the East Midlands Alliance banner. So for example, the additional funding from Health Education England and from NHS England, the CAMS workforce challenges, etc., etc. And I'll take those as read. The second piece is the more detailed bit with regard to what's called the East Midlands Alliance Collaborative Agreement, and the executive have looked at this in some detail and I've made some comments and recommendations to discuss with the board to see whether these are supported and approved, and I pulled them out of the agreement and put them in this executive summary. So they're the 3 bullet points: 4.3, 5.2 and 5.3. And just to expand a little bit on the context of this, and it does relate to some of the conversations earlier this morning around the development of provider collaboratives. So the East Midlands Alliance is exactly that. It's an alliance of providers, which includes the 5 counties, NHS services, and the independent sector charity St Andrews. But it's not a formal thing. It's not a, so I use the word thing to signify that it's, if you like, it's a statutory body, and the East Midlands Alliance isn't. It's like-minded people working together collectively to improve services and outcomes. Whereas when I discuss the provider collaborative impact, that is a thing. So that's got a legally binding contract, and one of the concerns that I have is that in this collaborative agreement draft, those 3 bullet points could be interpreted as blurring the edges between the Alliance, the East Midlands Alliance, and the provider collaborative as described there in those 3 paragraphs. So, for example, in 4.3 and where it's in italics, withdrawal from the East Midlands provider collaboratives will be managed in line with withdrawal procedures, including notice periods and surviving terms set out in the respective partnership arrangements. So on the one hand, you could say, well, that's quite clear that it delineates provider collaborative from East Midlands Alliance, but our contention is that this isn't an East Midlands Alliance collaborative agreement and doesn't or shouldn't impinge on the provider collaborative work. And the same pertains to 5.2 and 5.3, and again, it's in italics is the bit that's, or parts of the that we've got issue with. So hopefully people have had a chance to read this and take a view. That will be our recommendation, that we take those out and go back to the Alliance and say that we're content with the collaborative agreement otherwise, but we'd like to maintain that real clarity between the East Midlands Alliance being a force for good but not a thing, and the provider collaboratives, which are well described in their various legal contract arrangements.
Right.
Happy to leave it there, Paul, and take comments and views and questions. Thanks.
Thanks, John. I've got a comment I'll bring in after others. Manjit, please.
Yeah, thank you, John. I agree with the spirit of the paper and where we're trying to get to with this. My question's about the relationship between the Alliance and the priorities that we agree in the Alliance and where the ICB sits, and the interface between the work that we do in the Alliance and the ICB. Could you just comment on that, please?
Yeah, do you mean the Nottinghamshire ICB as a thing that's about to become statutory in July?
Yes.
Yeah, that's a very good question, as ever, Manjit, in as much that ordinarily you'd expect there to be some quite well described channels and flows to and from, but because the I think largely the different stages of maturity, in as much that the ICB is very emergent, isn't it? And you know, it's still not been gone through Parliament. It's likely to, I'm sure, when we're not quite so sure. So that's the one end of the equation, which is still to be described. And of course, it's really important because when you talk from a pathway perspective of these patient groups, there's a whole load of provision and commissioning that traditionally would sit under local CCG brackets, the new ICB umbrella. And that's the part that we're still in a bit in the dark about, really. Hence, you know, some of our concerns around this being so prescriptive. Once again, Sarah's popped into my vision. I don't know whether, Sarah, you might want to add something a bit more considered to my, off the top of my head, response.
Sarah?
Thank you. What I would add to that is for provider collaboratives that have a legally binding partnership agreement, that relationship mandate, I think, is very clear with clinical commissioning groups today, and therefore I suspect when we move into an integrated care board it'll be clear as well. So I think that bit is clear, and I think it goes back to the function, doesn't it? That is very clear in a legally binding document, but has to be articulated in a more voluntary alliance agreement. And I would echo what John says. I think it is early days to be able to articulate for an ICB what that relationship will be between the ICB and the alliance.
Yeah, I get that. I mean, what I'm worrying about is tripping over kind of the ICBs will be a thing, won't they, fairly soon. If our alliance arrangements are a voluntary arrangement, which takes us to kind of where we want to go. We've got the provider collaborative landscape here. It is about making sure that we don't knock out the ICB kind of intention and value at the expense of kind of taking forward the alliance work. I'm just anxious that we make sure that that triangle works for us and our patients in the way that we want it to, without it getting messy or competitive. That's my kind of anxiety about where we sit with this work.
I think it's a good summary of that to keep an eye on, Manjit, and obviously that will also be the case for a number of other integrated care boards relationships across the alliance. So I think it's a good call just to put a bit of spotlight on that. The only thing I wanted to add to this was just a reflection that I know that we'd seen earlier versions of this in different contexts, John, and I appreciate the fact that the exec took time to really just do a line by line go through to make sure that this was exactly right. And I think that the recommendations that you've brought forward for us to take those changes back are, I know that they came out of a very considered session that the executive team had on that. So I'm not seeing any other questions or comments. We're asked to receive the broader update, agree those changes recommended, and to approve the collaborative agreement with the changes described in the paper. I guess if our colleagues in the rest of the alliance don't agree with those, that'll bounce back to us again, John, in some form. Yeah.
Yeah.
Okay.
Yeah. It's got as the clues in the title, the Common Board paper is going to all public boards across the other organisations over the next month. So yes, we'll keep you updated on the progress.
Thanks. So colleagues, could I ask for an indication of if you approve on those actions on that basis, please? That's great. Thank you. Okay, let's move on to item 20, another one that was flagged slightly earlier, Anne-Maria, the safer staffing report, please.
Yeah, thank you very much, Paul. My name's Anne-Maria Newham. I'm the Executive Director of Nursing HPs and Quality, and what we have here today is the Safe Staffing Report. So as I described to you earlier, we've done number 1, which is have we got the right establishments? This is now the Safe Staffing Report, which will basically provide you with information around where we've got issues, where we've got levels of concern and what we're trying to do about it. So this paper is to provide some assurance on the Trust's ability to deploy the right staff with the right skills, the right place and time. And again, this is something else that's required by NHS England Improvement and the National Quality Board. We're required to do this on a regular basis. So I've got on page 105 some of the executive summary, but I'm just going to pull out a couple of points. So I'm going to pull out the unfilled staffing hours have increased within the previous 6 months in all services within the Trust. And this has been really felt. And I know that Dr. Elcott said to you earlier, you know, the staff are tired. We have really felt this over the last 6 months. It has been hard, it has been difficult, and we have had some really big staffing challenges, the same as all other trusts have, but we have really acutely felt it. And then also with Dr. Atfield, who said to you about the fact that we were at Opal 4 and they've been running at Opal 4 for some considerable lengths of time. And this is all the things that I'm going to be describing to you and the impact of all of that. So the most significant increases have been identified, interestingly, within Lingsbar Hospital, Wathwood Hospital and the mental health services for older people. So the mental health services for older people have undertaken an establishment review, and that does indicate there is a change needed to the budgeted establishments. So that's the pillar 1 that I described. So a business case has been done, presented, and we've previously approved that, but they still need to do the full recruitment to those posts. With regards to Wathwood Hospital, they've undertaken an establishment review which has not indicated any changes within the required establishment, and a lot of that was due to the professional judgment of the teams, where they felt that they had the right staffing levels, if they could get the staff on shift, of course, and there wasn't any vacancies or any sickness or absence. So overall, the number of hotspots has changed from predominantly high fill areas. So what I used to report on is if areas had high fill, which was above 115%, and if they went over 115%, that was a saying that we've got higher complexity of patients, therefore we need much more staff to the budgeted establishment. So we need more staff than what we're budgeted for. But more recently, so I used to always report on high fill rates, whereas in December we only reported 1 high fill ward, which was really unusual. So this shift has been attributed to the reduced ability to staff all the shifts. And this is what we've been saying before, even with bank and agency, we've really struggled, and we've done a lot of redeployment of staff from areas with a lower level of clinical acuity to areas which need that clinical safety from staffing. And then the only other thing I just wanted to pick out as well, and it is on page 106, the second bullet point, is the unfilled qualified nurse shifts has remained at around 20% to 25% for the previous 6 months. And that's a slight increase from the 6 months previously, which was 15%. And I'm going to now go to page 107 on the unfilled ward staffing hours. So the unfilled staffing hours has ranged between 19 and 22% over the last 6 months, but that position has declined now to 14 to 17%. So that's the inability for us to be able to fill the staffing shifts with either staff doing extra shifts, bank, agency, redeployment. And then I'm moving to page 108, which is about the hotspot areas. So one key metric to help us understand the pressure within the trust is the ability to deploy safe and effective staffing. So that's the total number of hotspot wards that we have. And those are the wards that have been identified due to the sustained deployment of either significantly higher or significantly lower numbers of staff compared to the budgeted establishments. And then also the change from high fill, so that's, you know, more staff than is budgeted, to low fill has been down to an inability to meet the required staffing. I'm going to page 109 now. So over the last 6 months, a number of ward areas have been consistently identified as low, and the majority of those are Rampton and Wathwood. And that correlates then with what I said to you in pillar 1, which was the establishment reviews. Rampton has had the biggest problems with regards to filling their shifts, and on occasion they've had to really move staff around, and they've only had 1 qualified per 2 wards. Adwick Ward and Cheviot Ward have a large number of patients within their population which are subject to long-term segregation. Sometimes you'll see that called LTS, but that is long-term segregation. And that is due to high levels of risk, and as such interventions are pre-planned. So there's lots of care planning that's done around any patients that have long-term segregation, and we also have to report that as well. So those numbers are reported on a regular basis, and you would always see that. And then on page 110, We're just doing some work across all 3 divisions to review the particular pressure using workforce profiling. So we've got some expertise in to the trust around workforce profiling, and that's to basically identify any areas of innovation for expanding existing roles or the development of new roles, which both Jen Guyver and myself referred to earlier. So workforce profiling looks at different kind of roles that can be brought in to be able to support the patients and also be able to take on different roles to add addition really to the establishments. And one area to note is within the month of December and into January, a number of wards at Rampton have deployed 1 qualified to oversee more than 1 ward at night, which is what I mentioned earlier. And also, I think Jen's going to mention it later, so I won't take her thunder, but that's about the international recruitment that's just mentioned on that page as well, but I'm not going to say anything more about that because Jen will mention it later. And on page 111 you can see the ongoing project work that we're putting in place there. Really interesting work around the workforce profiling and rolling out the acuity and dependency tools, and also we're now moving into doing the community establishment reviews, which we've never really been able to do before. There was never a tool for us to do that, but actually Keith Hurst, which is a national Keith Hurst tool, he's now doing that. And I just wanted to say that we are one of only 7 trusts in the country that is doing that community establishment review. We've just sent in all of our data, so we're ahead of the game on that one. And then on the last page, 112, we've got a safer staffing page which is now live on Connect. All wards have a safer staffing poster, we're displaying the actual staffing levels per shift. And we've also just got the licence procured for community health services to be supported to do their staffing levels and safer nursing care tool as well. So the board is asked to receive assurance on the trust's ability to deploy the right staff with the right skills at the right place and time.
Great, thanks Anne-Maria. We've got a couple of questions lined up. Carolyn first, please.
Thanks Anne-Maria, and thank you for your explanation. I've got a real echo. Is that a problem for other people?
Could you just mute yourself, Anne-Maria?
Thank you. Your explanation of safe staffing and the establishment reviews before, hopefully that's really clear to people. This paper I think is really worrying, and we did, as I said before, talk about this in detail at the Quality Committee. And whilst I'm assured that you're doing everything that you can do, what I'm asking is seeking assurance about the impact that this has on patient care, the quality of patient care. You've alluded to the fact that staff are very tired, and in the paper somewhere it also talks about an increase in incidents. So I'm just looking for some sort of assurance about how we're monitoring that in terms of patient quality, incidents, complaints, and trying to triangulate those, because this situation has been deteriorating over a number of months, and despite everybody's best efforts at the moment, doesn't seem to be getting any better. And I know there are sort of medium to longer term plans to improve that, but clearly you're in the process or in the business of managing this on a day-to-day basis.
Just take myself off mute. I mean, I think you pose a very difficult question for me, Carolyn. It's very hard to give a level of assurance when we are working with such challenging times. And, you know, I can honestly say I'll have done 40 years on the 1st of September this year. And I probably would say to you that staffing and being at sustained level 4, OPAL 4 for such a time is unprecedented in my kind of like nursing career. And I'm not sure about the level of assurance I can give you. What I can say to you is that every single day we do take care of how many staff we've got on, have we got the right skill mix, have we redeployed all the staff that we possibly can, have we moved people around. I mean, the amount of redeployment that's been done is huge. We've taken everybody out of managerial posts that can be taken out of managerial posts, anybody who can work in clinical shifts. Matthew, who's actually put this paper together, he's been working 3 days a week clinically rather than doing the staffing kind of like reviews as he would do. I mean, we've done as much as we possibly can. With regards to harm, patient harm, we have seen some increase in incidents, but again, it's something that we monitor on a daily basis. We've got some really good processes to understand why it happened and doing debriefs as well for both the patients and the staff themselves. I don't know whether or not my operational director colleagues want to say anything about what they're actually doing within the divisions, but certainly from my perspective, what I presented today, that's the level of assurance I can give you.
I think Sue Elcock, do you want to come in on that point?
Yeah, thanks. Sue Elcock, Forensic Director. I think, Caroline, what you've asked is exactly what we said we want to do, because we know that December and January have been our worst 2 months. And so now we can actually look at the data retrospectively to look at that triangulation of incidents, complaints, patient activity levels, etc. All the things that we should do to give you, well, to give ourselves assurance of what has happened, what has been the impact, and so that we can show, because one of our key principles, certainly in forensic, that I've emphasised to the board before, was about the equity, so that we made sure that if we did have to reduce, for example, access to activity, it wasn't done as a standard across, a cut. It was done fairly, so that everybody, if we had to do it, lost a little bit, if I can put it that way. So I think we're in a position now, if you think we're just, it's the beginning of March, we can now get that data to look at properly for those 2 months in particular.
Thanks, Sue. Keely, I think you want to come in on the back of that as well, and then I'll come back to you, Carolyn.
Yeah, so just as Anne-Maria mentions, Carolyn, we've instigated weekly meetings with regards to the ward staff over at Lings Bar, because I totally agree with Anne-Maria. I'm equally not fully assured around his current position, so hence why we're trying to seek that assurance, but also in a supportive nature with our ward staff around what the art of the possible is around some high impact actions. The story that we're currently seeking is it's multi-stranded, so whilst we are recruiting, we're not recruiting quick enough and the bath water's leaking out of the bath quicker than we can fill it. So we need to look medium term around as retention strategies over at Lings Bar Hospital. In addition to that, it's at a time where we have been impacted by multiple outbreaks, and I'll say multiple outbreaks, it's compounded as vacancy factor from absent rate to the point where we saw John Proctor in a complete loss of 38%. So we knew that wasn't a safe and sustainable position. I think there's some things that we can do internally around getting Lings Bar to view itself as a collective. I think sometimes the wards operate in isolation and don't share the staff as much as they can. I think there's some unwanted variation around how we do health roster that's within our gift, and also how we coordinate planned absence. So when we've got heightened sickness, how do we negotiate around a reduced planned absence rate for annual leave, etc., to keep us within those safer parameters? So that's all the dialogues that we're having in those weekly meetings to ascertain everything in our gift to get us into a brighter picture moving forward. But currently, as I sit here in the spirit of honesty, I've only got partial assurance, hopefully moving to assurance as we continue those dialogues.
Okay, Julie, do you just want to add in briefly a perspective on this as well?
Yeah, I mean, I would say, Julie Atfield, Director of Local Mental Health Services, the whole situation around managing staffing and patient need has changed, particularly across local mental health services. The daily demand procedure is really quite tight and very focused on mitigating some of the impact of this, and also diverting clinical acuity when we're able to do that in relation to staffing as well. So sort of local procedures have changed considerably, and everybody can articulate and describe that and how that works and what are the benefits of that. I do feel there's adjustment, if you like, to a new normal, if you know, to describe that, because we still currently have staff redeployed, and it's not easy to see a point where that can change actually. So I think there is some review and reconfiguration needed at pace. This is not just in mental health services, this is happening across the NHS to review how we do deliver some things quite differently actually, and using different estate, different models of care. So I think there's some proactive work to do around that, and I think there's something as well going back to monitoring some of the key fundamentals so that we are very clear about what the quality impact is, because it's not just about staffing rates, it's about, you know, some of our key quality measures, whether that's rapid tranquilization or physical health care. They're the things for me that a standard set of quality metrics that we're following around some of those issues.
Carolyn, do you just want to reflect on what you've heard there? Because
yeah, I mean, I thank you to everybody, and I know what difficult circumstances you're all working in, and this is kind of no reflection on your ability or capability. My concern is I suppose the question, the board's being asked to receive assurance on the trust's ability to deploy the right staff. I'm not sure that I am assured. I'm assured that people are doing everything they possibly can, but it feels as though we've got a significant gap at the moment. And I think when I come to the quality committee report as well, there are issues around training in some of our fundamental aspects of training that we haven't been able to do, and that is also presenting a risk. This is the most significant risk on our board assurance framework. So yeah, I don't feel assured. But I do, Anne-Marie, saying this is not a reflection on you. I do feel assured that you're doing absolutely everything that you possibly can do. But in terms of our ability to deliver the right staff in the right place at the right time, I'm not sure that we're doing that consistently at the moment.
Yeah, I think, and I've heard in the spirit of a unitary board, some of those reflections from executive colleagues are, I think, in a similar space of we're doing everything we can, and we're there's still some concern there. Let's take a couple of other comments first, Anne-Marie, and then give you a chance just to reflect back on this before we move on. Nigel, I've got you next, please.
Thanks, Paul. Hi, Anna-Maria. My question's kind of evolved listening to the previous discussion. I am in the same place as Carolyn. It's difficult to be assured when you look at the evidence and listen to that discussion. But my comments are in the spirit that Carolyn made hers, really, about not being critical, but just trying to assess how worried we should be. So I'm not assured on the current position. I'm not sure about how much better it's going to get and how quickly. And I just wanted to test, Anne-Maria, whether I've got the numbers right, because I'm looking at the chart on page 107, and the figure that's worrying me is 74,000 unfilled hours in the month. And I think that's about 350 or 400 staff. So what I'm getting at is, to close that gap, we would have to recruit that kind of number of staff. I know it's got to be in the right places and the right skills and all the rest of it. And the only plans I think I can see in the papers today is the 50 international recruitment. So I've still got a sense of where are those staff going to come from in the medium term.
Right. Do you want to respond to that one, Anne-Maria?
So it's not reflected in the paper, but we do the most phenomenal amount of recruitment campaigns. There's recruitment campaigns on Twitter, all of the social media platforms. We have ongoing recruitment. So there's a gap, there's a very small gap between how many you recruit and how many exit the organisation, and there's a small gap there. So whilst we're saying that we've got all of those hours unfilled, and it will take a lot of work to recruit into those hours. And we do have vacancy across the whole organisation, various vacancy, of course. Some areas have got very little vacancy, some areas have got huge vacancy, but there are masses of recruitment campaigns going on all the time. I mean, Jen's just come in, Jen Guiver's just come in from HR perspective, and she leads on the recruitment campaigns that we do have. But between our HR department and our communications team, they are doing some fabulous innovative work around getting people in and going to big recruitment fairs across the country and all sorts of different things. We've increased our students. We've increased our students phenomenally, who will then at the end of their training hopefully come and work for us as well. So there's lots and lots of other things. It's not just the international recruitment.
Oh, but realistically, are we going to close a gap of 350 to 400 people in the next 6 to 12 months? I doubt it.
Jen, do you want to just come in with any other perspectives on the back of what Anne-Marie has fed in there?
Yeah, so I think we need to link this all into our strategic workforce plan, which we don't have at the moment, but is going in draft form to the next people committee, which I think is the 17th of March. And that will broadly cover those 3 pillars that we talked about earlier. So attracting through innovative recruitment, accessing different markets, not relying on social media, going back to basics, leaflet dropping for looking for people from the local area, accessing our communities. Secondly, growing our own, so nurse associates, nursing degrees, etc. And thirdly, retaining. What that strategic workforce plan will do, Nigel, is detail the numbers for you. So you're right, your calculation's right. The 300, around the 300 mark around registered nurses is correct. What we haven't had written down through sort of 2020, 2021 is those numbers around how many are we going to put through the programmes. We've got the numbers around international recruitment now, but where are we going to target in terms of our recruitment campaigns? How many do we aim to get from each? So, for example, at the moment we're running a bit of a target around military personnel because we're a gold employer recognition scheme award holder. So we're advertising in some military magazines, but we need that to be part of a plan now rather than a sort of scattergun, let's try everything. So those numbers are going to the people committee in March with the caveat that it will be a working document that will continue to evolve.
Thanks, Jen. I think it's helpful getting that additional detail. Let's go to Sue Nixon and then John, and then I think let's try to pull this together. Sue Nixon.
Thank you, Paul. My name's Sue Nixon. I'm one of the non-exec directors. I would just like to say thank you very much, Anne-Marie, for a very detailed report, and I would wish to concur with my colleague Carolyn in the concerns that we've raised, and I would wish to emphasise that this area has had significant and detailed discussion at the People, Culture, Equalities and Inclusion Committee. And I'm pleased that Jen has actually just preceded me because she has said the very things I was going to invite her to say. My sense is that the workforce strategic plan is critical. However, from my perspective, as you will be aware from our last board meeting, we did share our concerns and we increased the risk in terms of safer staffing and capabilities and so on from 12 to 16 last time. And this was very much part of our debate. We've got to get further assurance. The thing I think that we'll need to be facing is actually the creativity of the different types of posts. We may well have to think of different types and ways and mixes of teams to fill these posts, and I think it's always going to be a tough ask. I was delighted to hear about the creativity that Wathwood have been picking up and so on, but it may well be that even when we go out for our recruitment, which will be coming in Jen's later report for 50 international members of staff, we may not get exactly what we want, and therefore the question will be back to us, is it the people that we want that we can then train with additional skills? So I think we've got a very challenging time here. So my comment really is we need to keep going in every vein possible. And I don't think there is one easy answer. I think it's a creative mix, and I'm interested to see what comes out from some of the people we've drafted in to help us suggest the different types of posts that we can include, like various other types of posts. Sorry.
Thanks, Sue. And just to and obviously, you know, you're in part restating what Anne-Maria and colleagues had described there about those multi-pronged approaches there. John, let's bring you in.
Yeah, thanks, Paul. Just very briefly, I think it's really important and timely conversations for the board to have, and whilst it's not a great place to be in, feeling that we're not fully assured, I think it's important to acknowledge that, you know, that's the reality of it. We won't be the only board in the patch or in the country that I would think be having the same sorts of conversations, and I think it probably reflects that without being complacent, we're confident as a board to be able to lay out exactly what the issues are, rather than pretending it's not an issue or that it's all going to be all right in a couple of weeks' time. You know, this is a huge issue for the NHS more broadly, isn't it? And to be blunt, we're in a bit of a pickle from a you know, national workforce perspective. But as we've heard, you know, there's an awful lot of I think some quite innovative thinking and work going on to try and tackle the challenge we have in hand. But it will play out for months ahead. Thanks.
Thanks, John. Anne-Maria, is there anything you wanted to say in reflection on the back of all of that commentary? Because I appreciate that a lot of this is going to continue to get scrutiny through the committees and the executive as well. But just to give you a chance, if there's anything you wanted to reflect back on.
Just to reflect back on Carolyn's level of assurance. So I think that personally, I think that there's a high level of assurance about things like the actual establishment reviews being done, the workforce profiling being done, the posters being displayed, the work that we've done with staff to understand what establishment looks like and what good looks like. So I think there's full assurance around that. What I can understand she would give a partial assurance to would be around the fact that we aren't able to fill the shifts. So they're two quite different things, but I can see where that level of assurance would come from. Great.
Thanks. I think that's helpful and a really important conversation for us to have. Colleagues, I'm going to change my mind around the agenda and suggest that we don't try and push on without a proper break now. I think we've got some important items still to come, and I think it would be better if we take a lunch break now. I know we don't usually do this in the midst of our part one, but I think it's important given some of the items that are left that will need a bit more time. Can we restart at 10:02? Does that feel okay for people? 10:02 to restart. I'm getting a nod from Sui. That will do for me, thank you. So at 10:02, if we can restart, colleagues, and please just get a bit of refreshment and time away from the screen. Thank you. Okay. I think we're about ready to restart. I hope colleagues got a chance to get a little bit of time away from the screen, and we will push on with item 21, global cyber security vulnerability. Sarah, over to you, please.
Thank you, Paul. So Sarah Furley, Director of Partnerships, and I've got executive responsibility for digital, which is why I'm talking to this agenda item. So the purpose of the report is twofold. Firstly, to provide board with assurance in terms of our systems and processes that we've got in place to reduce the threat from cyber attack. And secondly, to update the board specifically on our response to the recent Log4j vulnerability. Log4j is actually software coding, and I'll say a little bit more about that a little bit later. So cyber threats are a real national and international risk, and they impact organisations every day. As a trust, we have an IT security team that takes a very proactive approach to mitigate this threat, and they do it in several ways, whether that's through monitoring tools and firewalls, receiving alerts from NHS Digital and other intelligence from national and local groups. That IT security team have a governance infrastructure around them that has oversight of policies, updates and incidences. So if and when we receive high security alerts, it triggers a major incident within the IT team, and business continuity processes and protocols are put into place. Over the last 12 months, our IT security team have responded to 13 such high severity alerts. And in preparation for these type of high security alerts, which are now an inevitability, I'm afraid, they do a number of things. So they regularly scenario test and do desktop exercises. The last full scenario was in May 2021. They also maintain an information asset register which identifies our most business critical systems. And it helps them prioritise when we get this type of threat situation. They have the monitoring tools, as I said, such as firewalls, and they have visibility of all of our devices and applications because they're connected onto our network. The other thing that happens in preparedness is that all of our staff go through data security awareness training every year. And as I say, we get these alerts and intelligence from national groups. Despite the role that the information security team do, we can't be complacent about these cyber threats. And on the 11th of December last year, NHS Digital released an alert for Log4j. So, as I said, Log4j is a coding software. And it's used by many software developers as a building block in other software programs. And what it does is it actually logs activity. So what it is, it's a fundamental building block in software programs. So when that high severity alert for Log4j was received, IT went into a major incident. And they set about identifying the risks and taking the mitigating actions. And through that major incident, they actually met 3 times a day, 7 days a week for several weeks and put in a comprehensive and a robust response. So by January, they stepped down that major incident, but even today, they're still monitoring that situation. I can assure the board that all vulnerabilities have been mitigated, and today we have less than a handful of operating systems that are still under investigation. So I hope the board is assured that we've minimised the Log4j risk and that we have the systems and processes in place for what will be future cyber threats. Thank you, Paul.
Thanks, Sarah. It is an important one for us. Stephen, please.
Yes, good afternoon. Stephen Jackson, Non-Executive Director. That's a good paper, Sarah, and really assured by what you've said. I just wondered, in the light of very recent events and you know, particularly around Russia, that and a lot of commentators are predicting more cyber activity, shall we say. I wonder if you know, if we're taking any particular or special or additional measures to protect ourselves.
The short answer is yes, Stephen, we are. So Stephen Banks, our IT security and compliance manager, actually started actions last week, and we're currently waiting for some NHSE national guidance, but the actions are being taken to mitigate, and we are expecting an increased risk of cyber threats over the next few weeks.
Thanks, Sarah.
Fiona.
Sorry, just taking myself off mute there, and just building on the back of that question, and in light of everything that's just been shared, do we feel that the staff training being annual is sufficient to match the environment that we're currently in?
I think the answer is it's a difficult question, Fiona, when you look at the risk at the moment. And I think what the security team reinforcing me is that we shouldn't be complacent. I think the thing that we do is we do various scenarios and desktop exercises, and we very recently did a phishing exercise where we do penetration through our staff and then report back to staff the number of staff that responded to that. So whilst it's annual training, I think there are other things that are testing our resilience with our staff as well.
Great, thank you. Thanks, Sarah.
Great, thanks. I think it's good to know that we've got colleagues who are so alert around this area of activity. Sarah, and thanks for bringing that paper to us, yeah, we'll all be mindful around it, I think, particularly in the coming weeks. So let's move on, if we can, to item 22, the Security Services Quarterly Report. Sue, I know this is a regular one for us, and it's also an important one. Sue.
Thanks. Sue Alcott, Forensic Director, presenting this report. So this is mandated to come to the board quarterly. In a standard format in terms of two functions. The first is for the board to be assured that we continue to comply with the high secure psychiatric security, can't get my words out around my teeth. The safety and security directions is the first element of it, and then the second is a specific request for approval for a further 3 months of the use of nighttime confinement at Rampton High Secure Hospital. So in terms of what I'll draw out, because there is a lot of detail in here, which I know colleagues will have read. The one important thing in terms of the derogations was that, as I talked earlier in one of my earlier reports about December and January being the best testing time, we put in a further derogation against Security Direction 43 regarding training, which is highlighted in this report. And we're now back looking at the recovery plan, and there's information in there about mitigations that we put in place in terms of extending the training period of time that's allowed. I'm not going to go through it in immense detail because there's a huge amount of information, but rather than to say the second part is the request for approval for the ongoing use of nighttime confinement. So for those of you that perhaps are not so familiar with this, all patients across the 3 high secure hospitals, well, 4 high secure hospitals, including Scotland, have nighttime confinement in place, and that's where patients are locked in their bedrooms overnight, in essence, unless there are specific exemption reasons, which are also given in the report, so that colleagues, I think, had asked previously if they could get a flavour of the type of issue. So on page 121, it describes a number of patients that perhaps either for seclusion or because of risks are on enhanced observations, and therefore the door wouldn't be locked. So I'll stop at that point. We've talked about lone working. It's mentioned in here, but I don't want to duplicate that conversation again.
Thanks, Sue, and good to get those reminders that this is something that it is a standard set of requests that we've got, and actually there's some additional data that we've had in there that's been requested previously. So I'm just pausing to see if there are any questions. I'm not getting any. So actually, colleagues, could you please give me an indication if you approve this, the requests around the compliance with the high security psychiatric services arrangements, and also for that continuation of night confinement? Thank you. Let's move on to item 23, a well signposted item on international recruitment project financial approval. Jen, over to you.
Hi, yes, we've referenced this quite a few times, haven't we? So I'm Jen Gwyver, Deputy Director of People and Culture, and presenting this paper today for final financial approval for our international recruitment project. And the detail of those financials have been considered and endorsed already by the Finance and Planning Committee during February. So I'll take the paper as read, but I want to give a bit of an update on progress to date and sort of the plan. So in terms of progress to date, we have now secured some financial support from our colleagues at NHS EI to support with this project, coming slightly higher than we were expecting at £213,000, and that is now agreed, and arrangements are being in place to receive the money. We've also gone out to advert for our international recruitment lead nurse, and the interviews for that are happening in the next couple of weeks. And I know that my medical staffing colleagues are also in the process of identifying which roles we want to allocate for an international search, and also securing an agency on a formal basis. The plan, as we've referenced earlier, is to try to recruit 50 international nurses per year. For doctors, year one, we're looking at 11, which is based on current vacancies, but that will flex because they're more individual searches rather than mass recruitment, for want of a better word. I think the key for this is ensuring that our project, our offer, and the structure and infrastructure we put in place is sustainable. The last thing we want to do is bring colleagues into the country and into the trust who are unhappy when they get here or are unhappy after a period of time and move on. So really clear both during the recruitment of the international recruitment lead, but obviously once that we secure somebody and get them into post, that the priority is having a really engaging, supportive experience for these people, both through the attraction process, but when they arrive. It's pretty intense when you arrive as a overseas nurse. You have to get through your OSCE to get your PIN within 12 weeks. So lots of lessons to be learned from colleagues who've done this before of how we do that in the most supportive manner, but also taking into consideration the whole person. So looking at their dependents, their spouses, arrangements around going back home, schools, all sorts of things to help people settle in. So the reason it's here is for financial approval, but I thought it'd be helpful for you to have the context really of where we are with it.
Thanks very much, Jen, and you've covered off the confirmations I was after around that holistic approach. Carolyn, bring you in.
Yeah, thanks, Chair. Carolyn White, Non-Exec Director. Jen, thanks for this. Just two quick questions. One is, I don't think, I mean, I've read it twice. The paper says where we're recruiting from, and I'm just checking on the ethical issues that we're not targeting countries that can ill afford to send their staff to us.
Yes.
Sorry, and then the second question, I think you've probably covered off really, is the importance of settling people and making them feel as part of our local community, because my experience of this in the past is that in Nottinghamshire, when we did this a long time ago at Sherwood Forest, we lost a lot of people because they drifted off to the big cities. They wanted to go to London or Edinburgh and what have you. So making sure that there's enough resource to be able to keep them locally. I'm not sure that's phrased very well, but you understand my sentiment.
Yeah, so I think we're on the same hymn sheet. So taking the first point, we're all new to this. So to some extent, the first step was to get somebody in post who can go into the detail to decide in the round which countries we do recruit from. There is now an international recruitment NHS EI Midlands team with some associated expertise. There's also a list of sort of accredited countries that we should recruit from, or it's okay to recruit from. So we'll be using their expertise as well as sort of the formal documentation that's available. Taking a second point, to get into sort of the operational practicalities of it, the small team will have a lead nurse, but they'll be supported by 2 clinical educators. But my view on that is that those clinical educators' first job will be to get people through the ROSCE and get, sort out their NMC PIN, but they're going to be much more than a clinical educator, and I see them as kind of their buddies for the long term in terms of that holistic settling in programme. So more than just education and more around the whole holistic offer, really.
Okay, and have we got resources built into this for that, making sure that they've got adequate housing, transport, all that sort of thing, their transport backwards and forwards to wherever their home might be?
Yeah, so there's indirect costs, which is the supporting team to obviously recruit, look after people, but there's some direct costs, and they're estimated using sort of national information and with help from neighbours at being about 13k per recruit in the first year. And then once we settle into the programme and we develop some internal expertise, that drops to about 10k. That covers things like flights, taxis from the airport, welcome packs, visas, COVID tests. It's a huge list, and so that's all factored in per nurse.
Thanks, Jen. Could you just clarify what that acronym OFSCE, whatever that one is, actually, what it's actually meaning? I was kind of assuming that this is a sort of a professional piece that people need to step through. Is that correct?
So essentially, it's a practical clinical exam. So you have OSCEs across different clinical specialisms, but the acronym stands for Objective Structured Clinical Exam.
Great. Every day is a school day, isn't it? Thank you for that. Stephen, you'd got a question, Stephen.
Yes, it was just to build very briefly on what Caroline said about the importance of making recruits very welcome. From personal experience, I know the effort that both universities in Nottingham go to in retaining students, because once you've gone to the expense of recruitment, the last thing you want is people to leave. So there's a huge amount of work has been done about welcoming people to Nottingham and all of that, which would be very relevant, and I'm sure that the universities would be more than happy to, share some of the detail. And if you need a connection, I can make it for you.
Thank you, that's really helpful. We've got so many connections that are all sitting in a sort of folder that I've got ready for when these people start, but we need the capacity first to start moving on it.
Okay, thanks for giving us a bit more of the context for this one, Jen. So we're asked that we approve the proposals to progress international recruitment and to approve the investment to fund the programme of work, and also note the progress will be monitored through People, Culture, Equality and Inclusion Committee. Could I get an indication from colleagues if you agree to support those?
Thank you.
Thank you, that's great. So let's move on to item 24. Shirley, the Board Assurance Framework that we call the BAF. Over to you.
Thank you, Paul. Shirley Higginbotham, Director of Corporate Affairs, here presenting the BAF, the Board Assurance Framework. This is presented quarterly to Board for assurance on the process. The process is quite well embedded now in that each strategic risk has an exec director who regularly review their risks, and then each risk is also allocated to committee who also regularly review and agree the score. All this has been done in the last quarter, and as Sue indicated earlier, Sue Nixon, the People Committee have also increased the score of the staffing strategic risk. This is now above its tolerable level. A tolerable level is what we've agreed as a board that we are prepared to tolerate. I think the fact that the score has now gone above that shows the discussion and relates to the discussion we had earlier about assurance about recruiting staff, etc. So I think it shows that the BAF is a dynamic document and reflects the heat in the organisation, which I think we'd all agree is around staffing. And I think the discussions we've had at board reflect that, so support this BAF document. Also included are the significant risks. These are overseen monthly by the risk committee and are reported to board for information, but just to provide assurance to board that these are regularly reviewed by a risk committee and they're all within their dates for update. So it's just here for further assurance or any further discussion. Paul, thank you.
Thanks, Shirley. And I don't propose we dive into the detail as you described there. I think the conversations that we've had throughout this meeting today around staffing totally support why we've got the rating that we have there. But we've talked a lot about mitigations that are in place, well, we'll test out with colleagues, but certainly for me that gives some of the assurances that we've talked about previously, but absolutely recognising the heat as you described it in the staffing area. I'll just pause to see if anybody wants to bring anything specific out. I know through our risk committee, which is a relatively new establishment, that there's a lot of scrutiny, and indeed through our board subcommittees as well, there is scrutiny against risks and the BAF.
Yeah, and that's where that risk will be reviewed again, and hopefully the mitigations acknowledged and the score can reduce to within the tolerable level. Great.
Okay, so we've been asked to review in the light of the proposed changes, which I think we have done with that steer, and then we're asked to approve the BAF. So could I just take an indication from colleagues around the board assurance framework, please? You can indicate if you approve. That's great, thank you. I know the committees give a lot of scrutiny to the parts of the BAF that go to them. So if we could move on to the reports from subcommittees, I'm taking these as read, so chairs, as you feedback on these, literally if there's any specific highlight that you need to draw our attention to as a board, please. Manjit, let's start with you from the commissioning committee.
Thank you. As the board will be aware, this is a newly established committee, and we had our first inaugural meeting a few weeks ago. I think that we've challenged ourselves about whether we need another committee on the board, and we had a kind of a robust discussion about kind of the purpose and function of this committee. I think that the discussion at the board today probably reiterates the need for the board to have a line of sight on our commissioning responsibilities. The purpose of this committee will be twofold. One is in relation to the provider collaborative landscape and the work that is being done for us as a lead provider in the provider collaborative space. And the second is our role and responsibilities as a board in terms of oversight of directly commissioned services. And as Julie pointed out earlier, we are seeing more and more of that kind of activity. We're discussing thresholds and kind of what comes, what doesn't come. But I think that it was a good start for our first committee. We will keep an eye on the issue of duplication across committees, but we are intending that this committee will be the vehicle for triangulation of concerns across quality, strategy and finance. So we're hoping that this will add value to the governance landscape on the whole. So that's all I wanted to say, Paul.
Great, thanks very much, Manjit, and nothing to escalate to the board on this occasion. In which case, let's move on to the highlight report from the audit committee, please, Stephen.
Stephen Jackson, non-executive director, and this time speaking as the chair of the audit committee. I'll take the report as read, if I may, Chair, and I would say immediately that there are no items to escalate to the board. The only thing that I'd like to mention in addition really supports the earlier session that we had from Shirley. The board will know that the audit committee's prime role is to provide assurance that the systems and processes and controls within the organisation are indeed working and appropriate, and we had a really good review on the risk management process, and the way that they feed through into the board assurance framework, and also the important role that the new risk committee is playing in all of that. And I think we were able to report that there's significant improvements that we've seen over the course of the last 12 months, and we were fully assured with the process.
Great, thanks very much, Stephen. And then if we could go, Carolyn, to the highlight report from Quality and Mental Health Legislation, please.
Yeah, thanks, Chairman. So Carolyn White, Non-Exec Director, Chair of the Quality and Mental Health Legislation Committee. At our last meeting, I think the key issues the key issue for escalation to the board was related to staffing, and we'd received the paper on safer staffing. I think that discussion has been well rehearsed already today. A couple of other areas for note by the board was in relation to training for News 2. Now, News is the National Early Warning Score, and it's a way of assessing a deterioration in a patient. And training for this has been delayed. We'd asked for a review paper to come back to the Quality Committee, and whilst all other aspects of the rollout of the News 2 work was going well, training is lagging, and that is because of the pressures in the operational system. Is a cause of concern, because obviously we want all of our staff to be as well trained in assessing deteriorating patients as possible. The other two areas were in relation to the CQC paper. Well, we didn't take full assurance, but this is really about the way in which the paper was written, and I just wanted to explain that in that we have been presenting outstanding CQC compliances for some time. The actions on those compliances have been completed by the Trust. We're assessing the sustainability of that because CQC have not come back yet and reassessed our compliance with those, they're still standing as outlying, where actually the committee felt as though we should be able to, with our own internal assurances, sign those off. We had a very detailed paper from Paul Sanguinazzi about public and patient engagement. It was a great development plan for the Trust, but there's some misalignment with operational divisional aspirations, and so we've just asked for that to go back and be reviewed with the divisions to make sure that those are fully aligned. We reviewed the BAF, has been already discussed in terms of strategic risk 2, and were assured that all actions were being taken. Thank you.
Great, thanks very much, Carolyn. I appreciate you updating us on a couple of items in there as well. So if we just move to any other business, there's just one item that I've got. John, you may want to go first. I suspect we're on the same piece here. John, do you want to go?
Yeah, thank you, Paul. I'm on the Sarah Furley page. I don't know about you.
Yep.
So it's Sarah's last board today. You will have seen her intermittently through the morning, and I just wanted to take this opportunity to wish Sarah all the best and a fond farewell as she's stepping down at the end of this month. Sarah's been a superb colleague. She's worked superbly with the executive team, with the board, and with the wider health and care environment in Nottingham. She's so highly regarded. Everybody loves her. She's the force of reason, good sense and sensibilities within the exec team, which is no mean feat. Just one story to finish off with. I first met and got to know Sarah working in Lincolnshire. She was working for the CCG in the forerunner of the ICS when it was called STP, can't even remember what that stands for, but she was always highly professional and inscrutable. And we used to have weekly meetings where we'd sit in a big horseshoe before the days of Teams and COVID and listen to the acute trust bemoaning what a terrible situation it was in, listen to the CCG about why they wouldn't invest in mental health service. And I used to text and email Sarah across the table with all sorts of flippant remarks. And I could never make her break into a laugh or a chortle, and she always used to deadpan me back. And I thought, there's a class act. And by happenstance and all sorts of good fortune, Sarah came to join us a couple of years ago. We will miss her greatly. I know all her colleagues in the exec team will miss her greatly too. And I want to say thank you for everything that you've done, Sarah. You've been a brilliant colleague, and to wish you all the well for the future. And sad to be hearing that it's your last board today.
Thanks for that, John. And Sarah, I would echo that from the perspective of the non-executive directors, and indeed also wider, thinking about our governors as well. I think for me, there's a great legacy that you're going to leave at our April board. I think we're scheduled to sign off our next strategy. And I think that may be coming to us as the Furley strategy, just to acknowledge the incredible work that you've done holding that and enabling a piece of work that has developed with such real co-production with not only our staff, but also with those who use our services. Whilst I know that our public who are observing us can't see, there's a lot of positive messages appeared in the Microsoft Teams chat line here as well, Sarah. So I don't know if you want to respond, Sarah. John's nodding, suggesting you should. You're shaking your head vigorously at me. So, but please, we do wish you well and thank you a great deal. Just absolutely, you've had a massive impact on the organisation. That's much appreciated. Colleagues, we always do a review of our meeting, and I think I just wanted to take just a couple of minutes to invite any comments from colleagues through on the meeting today. I know it's been a long meeting. It felt like it felt like we needed to get into some some differently important pieces today, but I'm also aware that there are a number of folk who've been in the board for the first time. So just pause to hear 2 or 3 comments, if I may, please. Anybody like to give a comment, reflection on the board meeting? I will want to hear 2 or 3 voices, please. Fiona, Nigel said yes, he will. I'll go Nigel and then come to you, Fiona. Nigel.
Sorry, I was just trying to find a word that I could type quickly, Paul. So yes, I will. I thought it was really refreshing, actually. I know I don't know whether we've overrun because I'm not quite sure when we're scheduled to finish, but it didn't feel overlong given the weight of the items to discuss. So I think you let it flow in the right places where we need to get into detail. But my overall comment is that I thought it was refreshing because there was no hint of defensiveness from execs. There was plenty of challenge. And I thought the quality of the papers was really excellent, actually, because I mean, I'm not quite sure where I'm measuring it against, but it answered a lot of questions that you didn't need to ask, particularly in the waiting list paper. I know that's a really tricky subject to express quantitatively, and I think that was really powerful. So overall, I was very pleased and refreshed, and I think I will come back again.
Thanks for that, Nigel. Good to know. Fiona.
Very much the same, completely concur with Nigel, and I just want to really highlight the professionalism of everyone, and particularly all the execs who have talked through their papers. The papers are outstanding, but the clarity, the knowledge, the expertise, all the hard work that has gone behind them, that is again really echoed in the articulation of some of the challenges which are complex. These aren't easy things, and you know, I have come in without any, you know, I don't work in the NHS, and for me to be able to understand all of what's being shared and be really able to absorb and comprehend, for someone like myself, is also a testament again to the expertise and professionalism. So yes, I have thoroughly enjoyed my first meeting, so big thank you.
Great, thanks very much, Fiona, and that your sentiments are supported by others around the table as well. So colleagues, just before I finish, just a couple of quick thank yous to Grace and to Lauren, who've been supporting us in the board, and also I don't know if it's Tony or Chris from our comms team who has been, I know, on social media tweeting about us. Really appreciate your attention with us today. Colleagues, we need to leave this meeting and restart our part 2. Should we start at past? And if we can go in via the other link, please. And thanks very much. So see you shortly. Thank you.